All right, everyone, it is 7 o'clock, so we're going to go ahead and get started. Thank you for being here. I'm Brittany Nichols. Welcome to the Heartland EMS for Children Coalition Spring Symposium. Tonight, we're going to be discussing how to care for children experiencing a behavioral health crisis. We're really excited to share more about this topic tonight, but before we get into our presentation, I want to go over a few quick housekeeping items. So first, as you might have noticed, you're all in listen-only mode. This just means that your mics have been automatically muted and your webcam's disabled. If you encounter any technical difficulties or need support, utilize that chat box function and we're going to follow up, okay? So second, all attendees must watch for at least 120 minutes and complete an evaluation in order to receive your certificates. The evaluations will be sent out after the symposium tonight, so please be patient and give your state coordinator some time to get those certificates to you, just because we have to go through these individually to meet our state and discipline-specific guidelines. But if you run into any issues, though, reach out to your state's EMSC coordinator and we'll help troubleshoot for you. And then finally, there's going to be a 15-minute Q&A session after each of our presentations. As you have questions, please type them into that Q&A box at the bottom of your screen, and that way we'll address as many as we can in the time that we have tonight, and we'll try and follow up afterwards to get answers to those that we just don't have time to get to. So I'm going to go ahead and introduce our first speaker for tonight, Mary Ann Hammond. She's going to be discussing how to de-escalate an acute crisis situation with a child. Mary Ann works as an education coordinator, focusing on autism and related disorders. She's helped found the nonprofit organization FIRE, dedicated to helping children with special needs be able to attend their home parish Catholic school, and her passion for advocating for children with special needs comes from experience with her own family. So Mary Ann, if you are ready, I'm going to turn it over to you.
Sounds great. So I'm going to share my screen. And here. Thanks for your patience. I'm back at here we go. So I just want to say thank you so much for the opportunity to be here. Whoops, I'm still not on the right screen. I don't know what's going on there. We'll get there though. But I'm delighted to be here. This is my favorite part of what I do for my job. And I love all these states because I grew up in Iowa. I went to college in Nebraska and Iowa. I lived in Minnesota for many years, and Iowa and Kansas, and have traveled to South Dakota and North Dakota. So I like you all. So thanks for the chance to be here. And I sure hope that it's helpful in helping you and what you do for your very, very important job. I talk specifically about kids with autism spectrum disorder, but I think any of the information that I give you could be tailored guidance for any child with a developmental delay or intellectual disabilities in general. So we always give a disclaimer. So it's an informational presentation, not meant to replace any tailored guidance provided by other qualified professionals. My examples might not be appropriate for your area of expertise or the things that you encounter. I sure hope they're going to be, but we just say that. And then finally, they're not necessarily those opinions of Children's Mercy or University of Missouri, Kansas City, where I am employed. So what most qualifies me for giving this talk, as I do many times a year, is our daughter Kaylee. And on the screen, you'll see our daughter Kaylee, who is 27 years old. And Kaylee has a profound intellectual disability and severe autism. She is completely nonverbal, and her cognitive function is about 12 to 18 months. So you can see she looks like a typical young woman. I don't think she looks 28. She usually gets guessed more at like 16 or 18, something like that. So she has a pretty youthful look, but there's nothing for people with autism or developmental disabilities that necessarily, by visually looking at them, you can tell that that's what they're dealing with. We say in developmental medicine that, you know, when you've seen one person with autism, you've seen one person with autism. And it's something that makes dealing with this disorder actually very difficult because you can't really group people together. I mean, we're going to talk about diagnostic criteria and things like that, but everybody looks a little differently. So it can really be difficult to know. And I'm going to give you some tips on how you might find out specifics about that particular individual that you're encountering. So this is my Kaylee. I say she's my College of Hard Knocks. And Kaylee has a lot of sensory seeking, as you can imagine, being about a 12 to 18-month-old cognitively. And we've had a lot of emergency room runs. We've had an ambulance, we've had a couple of hospitalizations, all due to some sensory seeking things. So what is autism spectrum disorder? So what I'm doing tonight is going to tell you about the disorder, and then I'm going to tell you about some tips on dealing with it, but I'm also going to show you a video that's done by EMS professionals. We are kind of narrowed. There's not a lot out there on this particular subject of actually seeing other professionals in action. So this is one that is available. It's the only one I know of. So I'm going to show about a 15-minute video and a few slides here, and I'll preface that when I get there. But first, we're just going to talk a little bit about the disorder. And autism is a brain-based difference. It's obviously a disorder. It affects social, communication, and behavioral domains. And again, it looks differently in every one, but these are the things that are mainly affected. It's a spectrum disorder, meaning that it goes from mild to severe. And we'll see another slide that kind of breaks down the specifics of that. And honestly, its specific causes are unknown. We are pretty sure there's a genetic and environmental risk factors, but in some studies they found one gene involved, and others they found 100. So there is no hard and fast criteria for saying this is what causes it. There's still a lot of people studying it, and I'm sure there will be until we get it figured out. Interestingly enough, of statistical interest right now, it's 1 in 54 births. So autism is America's fastest growing developmental disability, meaning that it's in every state in the United States. Actually, it's on every continent. I mean, it's not just the United States, but this is where we are, where we live, 1 in 54 births. Again, it impacts communication and social interaction. And many people will also have repetitive and restrictive behavior. And the reason why I circle communication and social interaction is this is what you use to do your work. And these sometimes are areas of great deficit. So you're really going to have to pull out your best skills and creativity in dealing with people with autism. Again, some specifics hopefully will be helpful with dealing with anybody that has a developmental disability. A few more statistics is that it's much more common in boys than girls, about 4 to 1, interestingly enough. Also, I've heard said that the girls that are affected sometimes are affected more severely. My daughter would be a case in point in that. She is significantly affected, being nonverbal, having a low cognition. So that rings true for me. It's also more common than cancer, AIDS, and diabetes combined. So it is really, really out there. And if I was in person with you all, this would be the point when I would ask for a raise of hands of how many people themselves are impacted by autism spectrum disorder. Who has a person that they love or that they know of or is a family friend that has autism? And I'm sure many, many hands would go up, probably at least 25% of your hands, to which I always say, good, I'm so glad that you have some of these people in your life, because there's some really special things about them. There's really some things to be learned. One thing that we know, and we're going to touch on this a little bit more too, is that the #1 cause of death in ages of people with autism 14 years and younger is accidental drowning. So we know that they have a propensity and a love for water. And so why is that important? Well, if a child with autism elopes and goes wandering, we say go to the nearby bodies of water first. And so that's just something to keep in mind on a search and rescue thing. Even when parents have not necessarily known that a child has a propensity to water, this is where they've been found, and it can often be tragic. This is another question we get with every talk that I give, and it's a one that we really need to spell out. And we always get the call of, tell me about whether or not vaccines cause autism. Interestingly enough, this originated back in 1998 by a research paper that was done by a UK doctor, and the Lancet, which is a prominent medical journal, published this information and suggested that vaccines could cause autism. Well, that information got out there, and it was the MMR, the measles, mumps, and rubella vaccine. And that was in 2010, and it was refuted. It was said to be false. The doctor admitted falsifying evidence. They retracted it, but unfortunately, as we know, sometimes the good news doesn't always make as much of a splash as the bad news. And so still today, by parents, by professionals, by so many people, we're still trying to debunk we're trying to bring out the truth here. The CDC says there's no convincing scientific evidence of harm caused by low doses of thimerosal. Thimerosal was the preservative in the vaccines, except for minor reactions and redness and swelling at the injection site. The CDC has done 8 studies to this effect and not found to be able to link, vaccines and autism at all. Period. So the take-home message is that vaccines save life and don't cause autism. Personally, I think that even with the COVID vaccine, this particular, situation is one that's causing some people to be, reticent or hesitant to get the vaccine. And this is a falsehood. This is not right. And so we are always saying vaccines, there's always a risk with the vaccine, right? That's why as parents, when we go to our pediatrician office and our kiddos get different vaccines, we have to, put our initials on the vaccine lot number and whatever that our pediatrician or our family practice person gives us. But what we say and what we know is that vaccines save lives and don't cause autism. So if there's nothing else you remember tonight, which I hope you remember a few other things, this would be the one thing to remember and to tell people about. So our objectives are, I'm going to talk about a little bit more about the key characteristics, which we've already talked a little bit about, those that are important to know in an emergency. So I'm going to explain how best to communicate with a person with autism. So a lot of just practical tips, and then describe some de-escalation techniques that would be helpful in an emergent situation or while you're trying to secure for transport. So now I'm going to show you that video, and I hope what you can do while this video is playing is I hope you can look at the specific instances and the way these children react in a real life situation. Look at examples maybe of that repetitive and restrictive behavior. Look at their physical responses, look at their visual responses, just kind of take in everything you can and look at what the EMS and the fire professionals are doing, because they're doing a lot of things right in this case. And so there's some really good visuals that you can learn from, and I hope this is helpful. And then after this, I'll come back on and go to my next slide. So here we go.
Engine 12, respond to a traffic accident. Single car into a pool. Reported 4 victims per RP. Possible autistic children in the vehicle.
Hey, that man has autism.
He has autism?
Yeah.
So he doesn't understand anything.
Be advised that a person with autism resides at that residence.
21st century fire rescue and emergency medical calls are never routine. You learn to expect the unexpected. Calls involving people with autism require special skills and tactics. The call may be due to fire, accident, or a missing person, and may result in a trip to the hospital emergency room.
I'll take box 31 for a structure fire. That's box 31 for a structure fire, number 590 Fisher Street. Responding apparatus be advised that a person with autism resides at that residence.
People with autism will display no obvious physical markers to alert you to their disability, but you may observe persons covering their ears or eyes, rocking, or hand and arm flapping. Others may be nonverbal and express their needs by pointing.
Time out 12:43.
What we'd like our first responders to know when they arrive on a scene and they have to deal with a person with autism is to expect the unexpected. Anything can happen in an instant. These people can go from 0 to 100 in a matter of a second.
Bill Canada is an autism training expert, captain with the Westwood, Massachusetts Fire Department, and the dad of a son with autism.
We try not to restrain these people. We may have trouble doing that. The best thing we can do is have a de-escalation of the behaviors. Let them calm down. This may take several minutes, but it's the best thing we can do. Once they're calm, hopefully we'll be able to transport the person without restraints. If we have to restrain, we have to be careful of the aggressive behaviors because they will bite you, they will pinch you, they will pull your hair, they will do anything to get away from you. So this is what we train our responders, that they could encounter this problem.
To prevent dangerous wandering, families may use extra locks and install plexiglass windows. Locked exterior and interior doors will be an obstacle for rescuers. Forced entry tools may need to be used throughout the house.
Make sure you check the closet. Don't look to your left, Johnny.
The person with autism, whether adult or child, may be likely to hide from rescuers.
Looks like up there, straight ahead. Make sure you check the top underneath the bed real quick.
Thoroughly search closets, under beds, and behind furniture. The person with autism may respond to your rescue efforts with resistance or aggression. To quickly move a person, be prepared to wrap them in a blanket with their arms inside. This may calm them down and prevent thrashing.
It's all right. Okay.
The person may remain a bolt risk after rescue. They may actually try to re-enter a burning building.
Good. Come on, buddy.
For safety's sake, assign rescuers to stay with or near the child or adult.
It's okay? Okay, son. You're a good boy. boy. Look at him. Good job.
The person may become anxious and unable to communicate.
Good.
Your mom's gonna be here in a minute, okay?
You doing?
Take your time.
Doing good, buddy.
Be patient. Allow the person as much space as possible.
Good job.
Watch out for anxiety and sudden outbursts.
Okay. What's your name?
We've got Mom on the scene now.
Mom's here? Okay.
Expect delayed, nonverbal responses to your questions.
You heard anywhere? You heard anywhere, Ted? Huh? You heard anywhere? No. Nope. We're not gonna hurt you.
Be alert. The child or adult may be attracted to shiny objects, close into your personal space, and actually reach for your badge, insignia, or other clothing.
It's okay.
They may be frightened by your mask, helmet, breathing apparatus, or turnout gear.
You're a good boy. Look at him. Good job.
Anything shiny, they might be either avoiding, scared of, or want to reach for it and touch it and investigate it. It's a wide spectrum.
San Diego Fire Department Captain Ralph Carrasquillo is an autism training expert and the father of a child with autism.
Sights, sounds, touch, odors of life that we might take for granted or we are able to filter out, but to an autistic person is just overwhelming. Sensory issues, just trying to take their pulse, and they might pull away from you because they feel that is actually painful to them, and they get a sensory overload because of that.
The sights and sounds of sirens and lights and life-saving equipment may cause a negative reaction from children and adults with autism.
You will not be able to help them until you decrease that stimulation, whatever it might be, whether it's our sirens, whether it's our shiny badges, whether it's our gloves that we're wearing, whether it's too much noise, too many people in the room. These are all things that we need to think about and decrease the stimulation.
Oh my God, is that an accident up there?
Yeah, pull over. Let's make sure everyone's all right.
Call 911.
Okay. Yeah, 911. There's an accident. It's at the corner of McCain and Bartlett.
While discovery may come from a 911 call from someone on scene, you'll discover the autism by observing an autism alert decal on a vehicle.
Yeah, and there's a sticker on the back that's about autism.
Engine 12, respond to a traffic accident. Single car into a pool. Reported 4 victims per RP. Possible autistic children in the vehicle.
San Diego Engine 12 responding. Hey guys, dispatch advises that possibly children with autism. Does anybody remember some of that training and dealing with them?
Yeah, I remember that IST focusing on children with special needs.
Okay, let's try to take some precautions in dealing with them.
Okay.
Driver seems kind of out of it.
Okay, did you see what happened?
Help.
Look worried.
Okay.
Search in glove box, sun visor, purse, or wallet for an autism information handout.
You guys, it says here that the children have autism, talks about some sign language and some verbal skills, and the fact that they like to wander off, so let's keep a close eye on them while we assess them.
Josh, I need a seat collar out of the C-spine bag. Okay, are you guys hurt
Oh,
anywhere?
you're not.
Where's the strap?
No.
You guys are not hurt anywhere. Did you guys have your seatbelts on today?
But I need to show me.
Okay. Donna, what we're going to do is we're going to take it to that hospital, okay? And then we're going to take it to school, okay?
No, I'm scared to go to the hospital.
You're scared, sweetie?
I'm scared to go to the hospital.
Oh, it's going to be just fine. Let's just try to treat them appropriately, but not try to get them scared or work them up.
Okay. I don't think they're going to tolerate any type of style.
Okay.
At that point, take out the head.
Oh, you are a great boy. Here, let's go over here. Don't, up. Let's not go far. Here, look at, I got a fancy seat right here. Can you sit right here for me? Oh, I don't want you to go in the traffic. I don't want you to get hurt. Let's go over here and watch with mom. Is this your mom? Nope. All right, it's okay. How about we just stay right here? Okay. Which way do you want to go? All right, well, we can't go in the road.
It's gonna take a little bit longer at scene, and we should know this. When we hear that word autism, I'm talking 10, 15, 20 minutes longer at scene, but the outcome is gonna be, you're not gonna be wrestling with that patient. You're gonna be able to walk them or coax them into the ambulance or where you need it to be. And the outcome's gonna be better for us as fire or emergency rescue personnel, and also especially for the child.
Keep on walking.
Keep on walking.
We gotta be careful of traffic, remember?
Oh, look at Aiden's in there. He's having a good time.
You guys are doing so good. We're just gonna sit. See, look at, there's a seat right there.
I can help you
We're
up
not
there,
gonna
okay?
go anywhere. We're just gonna take a seat. It's a big step, but you're a big boy. Can you do it?
Ma'am, we're trying to calm the children down right now, and as soon as we get them buckled up into the seats, we're gonna bring the gurney into the back of the ambulance here, and we'll get you guys underway. Get you up to the hospital as soon as we can.
Okay. Some children and adults with autism will become anxious and upset when getting into the ambulance. Others may be oblivious or curious about the whole experience.
Okay.
Try redirecting or distracting negative behaviors with the use of toys or verbal cues. Be calm. The person may be observing you to find out what to do.
Then an autistic person can go off like that. I would want very much to get that person in a quiet environment.
Head ER nurse Mary Weisenfeld served as a first lieutenant at a frontline hospital during the Vietnam War. She's also the aunt of 2 boys with autism and advisor on autism books and articles. Consider the effects an ER visit could have on someone with autism.
When we're dealing with autistic persons, we have to realize that everything that's sensory is something that can affect them. The monitors beeping, alarms going off, the bright lights that shine right in their faces, the instruments we use to listen to their heart, to look in their ears, to monitor them, to do an EKG, everything is so unusual that it might frighten them. You're going to put this person in a room that's quiet and work with them in a quiet way. Only use the lights you need to use, and don't be, subjecting them to things that we don't need to do. I wouldn't leave them out in the middle of the triage area with screaming babies and irate people and blood and everything else that goes on. I would take them and put them in a quieter place and do the triage from there, and then decide what they needed. And then once you make that decision, you go on from there and find the quietest place that you can accomplish what you need to for this person.
Ask the care provider about the person's ability to respond to pain scale and triage questions.
Okay.
Be aware that while some people can communicate verbally,
I can slam down.
others may use American Sign Language, pictures and phrases, or communication devices to express their needs.
I need help.
If you try and say, sit down there and wait for me, they may be going off causing you so much problems that they're going to take up 10 times more of your time than if you would take the initial time to deal with them and put them in a quieter place.
Despite your best efforts, the ultimate tragedy can occur. Help families coping with the death of their loved ones to find some closure and meaning to their personal tragedy. We hope this video helps enhance your understanding of autism. With your patience and understanding, people with autism can learn to live and love as we all do.
Love you.
So there was a lot of things in that, and we'll talk about some specifics, and certainly you can ask me some questions at the end or through the chat regarding some of the interactions there. There's always a couple things I want to say after I watch that. And one is when they came to the car that was in the accident, they said, you'll always know by seeing a sticker on the car. Well, honestly, I wish that was true, but I'm going to tell you, you can't depend on that. You can't know for sure. In fact, I'd say it's really the exception to the rule that they might have something like that on their car. I do on mine, and I think it's a great idea to keep information, you know, in the glove box of some specifics for the kiddos. But I will tell you, not everyone does that. That's not like you get a diagnosis and you get something to put on your card to designate. One thing that we do always encourage families to do is to get in touch with their local emergency providers and see if there is a sheet of information that you have devised that the parents or the guardians can fill out to talk about specifically about their child. And I'll talk a little bit about that down the line. But I just want to go a little bit more over the diagnostic criteria for autism. In 2015, there was a change from the DSM-4 to the DSM-5. DSM, probably as you know, stands for Diagnostic and Statistical Manual. It's kind of the Bible of psychiatric disorders. And before 2015 in the DSM-4, you can see on the left that autistic disorder, Asperger's disorder, and PDD-NOS, which stood for pervasive developmental delay, not otherwise specified, were the three different categories of autism. And then when the DSM-5 came out, they all became autism spectrum disorder. So although some people know to identify Asperger's disorder, for instance, as a higher functioning, usually verbal person, now that person would be given, rather than Asperger's, would be given an autism spectrum disorder. We're fine with them identifying with Asperger's disorder. I'm just telling you from a diagnostic criteria, they just would be called someone that had autism spectrum disorder. There was 3 symptom areas in the DSM-4. That was social interaction, communication, and again, the restrictive and repetitive behaviors, stereotyped patterns of behavior, interest and activities. Well, we kind of simplified that and took it to 2 symptom areas. So rather than social interaction, communication, and restrictive behaviors, we said social communication and interaction, because one of the things people with autism have such a difficulty in is combining the two, how social communication and interaction go hand in hand. And then again, usually they have that restrictive, repetitive patterns of behavior. And this would be the point where I would ask you, of the people that you know that have autism, what's their restrictive and repetitive behavior? What's their area of interest or their activity of interest? You would give me as many different answers as there would be people that know people with autism. Repetitive behaviors, for example, for my daughter, she turns in circles quite a bit, and she taps on things that she likes, like she's playing with those blocks. I don't know if you remember seeing in the slide, she often taps on top of them, then makes a circle, and then does it again. It's just an order that they have that kind of helps them experience their world and deal with it, and something that can kind of be calming. She also has just really a routine on different things, and I could give you so many different examples of other kids I know and what their restrictive and repetitive behaviors are. We have a kid that we saw in our clinic here at Children's Mercy so his restricted behavior was that he was really kind of over the top about readouts of time. So when he would get up in the morning, he would go into his parents' room and he would look at the clock on his dad's table, and they'd have to notice what time it was. And then they'd get up and they'd go downstairs to in their house, and they'd look at the readout on the video or your, what's running your instruments to do with the TV. So look at that. Then they go to the kitchen and they look at the microwave and make sure that these are really close or almost all match up. And you say, well, I mean, you're going to indulge them for all three of those things. Well, the reality is that was so important to that kiddo that you could throw off the whole day if you didn't go through those steps to understand that he needed to see his dad's nightstand, he needed to see the TV thing, and he needed to see the microwave. And then you could get organized enough to start the day. So these are just some examples of restrictive and repetitive behavior. In the DSM-4, the onset was prior to age 3, and now we just say onset is in the early developmental period. So that's the difference between the DSM-4 and DSM-5, and there's still, a little bit of confusion about it. Again, so, these persistent deficits. The other thing is that, again, nonverbal communication is something that many people with autism have trouble with. And what I mean by that is, we just pick up all kinds of nonverbal communication. What do they say? Nonverbal is more than 80% of the communication that we do, whether the way we're, the enthusiasm that we're using and speaking or not, or anger, things like rolling your eyes or a sign or being disgusted, or somebody cuts you off in traffic and showing them a certain sign, something like that. Okay, well, that all goes by people with autism. They don't get it. They're not picking up and understanding that nonverbal communication like you and I are. Even if they have typical cognition, they're still just not picking up that nonverbal stuff. And they have deficits in developing and maintaining and understanding social relationships in general. So I say, this is why junior high is so difficult for people with autism, because when you get in junior high, by that time, there's so much nonverbal communication. There's so many just funny things about developing and maintaining and understanding social relationships. Girls are starting to notice boys, boys are starting to notice girls, whatever it might be. And all of this is lost typically on most people with autism, on the nuances of things like that. I feel like almost every kiddo with autism should skip junior high and go right to high school, because by high school we seem to have a little bit of a acceptance and an understanding of who we are, and this is often really a tough time for our kids with autism. The restrictive and repetitive patterns of behaviors we've already talked about. Some have repetitive motor movements, like I talked about my daughter's tapping, use of objects or speech. They might have echolalia, which you ask them something and they repeat exactly what you ask, or they'll repeat a little bit about something that you said. They might take it out of context and keep going with it. They might be what we call hyperverbal, meaning they talk and talk and talk and often hardly take a breath. Or they might be completely nonverbal, like my daughter is. They often have those fixated interests that are abnormal in intensity and focus, like the example that I used with the kiddo with the clock. But one of the things that will really influence your job is this hyper or hyporeactivity to sensory input. Obviously, what you need to do is figure out if they're okay, if they're hurt, what the situation is. And some kids are both hyper and hyposensitive. That's my daughter. She likes a lot of deep pressure, but sometimes she simply doesn't like being touched at all. So you just kind of have to play with it and understand what might work. And I'll talk about, using the information from the people that know them best. And this might be how you get some of that really, really helpful information for what you need to do. We talked about the communication challenges and the deficits in that back and forth communication. For example, how are you? Oh, I'm good. How are you? Well, you might say to someone, And with the autism spectrum disorder or developmental delay, how are you? Good. Doesn't occur to them to ask you how you are, or they won't necessarily expound on something, or they understand something as it's said. They're very pragmatic thinkers, and that's how they understand things. They have, again, we talked about the deficits in nonverbal communication and understanding those social relationships. So these are some of the really specific communication challenges that people with autism have. The repetitive and restrictive patterns of behavior, the reasons why I want you to really hone in on this is that, you know how they said in the video that no matter what, at scene, it's just going to take you longer. And I will tell you, indeed it will, because again, you kind of have to wait them out, because just know that, for instance, their repetitive motor movements, their use of all these different things, it might be hand flapping, it might be rocking, as you saw in the video of the kiddo that got in the ambulance. You know, he was rocking back and forth, very common. Hand flapping, very, very common. Don't stop those things. Let them do it, because it is a way of coping for them, of you know, assimilating their surroundings and calming themselves. So we find that if you would try and put their hands down, or if you would try and take something away from them, you're going to escalate them more than, you know, have them calm down. The only time we say would be, you know, an exception to the rule would be if they're being self-injurious, if they're banging their head or something that could cause injury in itself, then you'll have to try and get them into a safe place. We talked about the insistence on sameness, and again, the hyper or hypo reactivity to sensory input. So let me give you an example with my daughter. The hypo reactivity is she can injure herself without even knowing it. I can't tell you how many times I'm like, there's blood, where is it coming from? So she can stub her, she just did this last week, she stubbed her toe, apparently. I mean, I just saw blood on the floor and I'm like, where's it coming from? Well, she didn't cry, she didn't sigh, she didn't do anything to tell me that it was there. She's completely cut herself, open herself, you know, with a small wound, and again, not even cried. So sometimes they have just a really incredible pain tolerance. And again, so that hyper or hypo reactivity. This is one of my favorite slides, because this kind of tells you how complicated autism spectrum disorder is. So it defies generalization, right? So if you've seen one person with autism, you've seen one person. Everybody looks a little different. So with intelligence, you see we have everything from impaired, like my daughter Kaylee, to gifted, savant, right? We all think of the Rain Man. Am I really dating myself when I say that? But Dustin Hoffman in the Rain Man, meaning savant skills, like he was great with numbers and things like that. We have a kiddo that used to be seen in our clinic that he could be seen a year later and he would come up and say, Marianne Hammond, 7/23/61, know my birthday, know, you know, exactly. And what do I mean, one time I told him that. And so they can just have some really cool skills. Their social interaction can go from aloof or kind of unconnected to active, but odd. Most likely they look a little different. And again, that social interaction, it can be really difficult. Their communication, we talked about a little bit, can be nonverbal to hyperverbal. My daughter has a really dear friend that I love, this young woman, but she is forever, Marianne, is Kaylee still have autism? Does she go to a day service like me? When is she going to get toilet trained? Why can't she do that, Marianne? Why can't she do that? And on and on and on. And she's darling, but it's just not giving time to answer, just keeps talking. We call that hyperverbal. When you have a child that's nonverbal, you really, the people that are hyperverbal really stick out. Restrictive and repetitive behaviors can be very intense to mild. These are people that aren't as affected with that particular aspect. You might not even be able to recognize that they have autism. The sensory, like I said, can be sensory seeking or sensory averse. Kaylee has had sensory seeking emergencies. What would be examples? Stuck her hand in the recycling can that I had taken almost all the way off and lifted up and rinsed out and then put in the recycling below the sink. I went down to change out some laundry for 1 minute. I had put her in the sink with an inch of water for her to get some sensory soapy sudsy water. And by the time I came up a minute later, she had gotten down off the chair, pushed it aside, gotten into the recycling, and stuck her hand in the can of, I don't know if it was tomatoes or something that I'd used for the enchiladas I was making that night. And when I said, Kaylee Hammond, when I came up, she pulls her hand out and I see blood just spurt up to my ceiling. And so she almost took off the end of her finger by getting it stuck in the can. Well, you know that I got a can opener that would never make rough edges again. And now I take off the top of every can instead of just lifting it up. But that was an emergency room run. She has stuck a dime up her nose, and she's stuck other things up her nose. She's ingested, I've called poison control so many times, sensory seeking. She's swallowed things that my husband had nasal surgery, a deviated septum. I found her in the kitchen. I had put his nasal spray behind a paper sack and she found it. We say she has a monkey reach. She found it and was ingesting the Afrin nasal spray. Well, she had a heart defect. And so of course that required going to the emergency room and being monitored for a couple hours. I mean, the list goes on and on. And again, it's just seconds. And so that's the sensory seeking. She's swallowed Bed Bath and Beyond spray that my teenage daughter, it just goes on and on. And so many parents can tell you, these are the things that the sensory seeking, sensory averse is really a hard thing to handle. They're Houdinis on getting out of locks and getting out. This is, the problem with eloping. I'm so grateful that my daughter doesn't elope. And then just finishing off this slide, they go from uncoordinated motor movement to very coordinated or quite coordinated. So this is how autism defies generalization. So you can't just say that they look like this or they look like that. There's just a whole spectrum of differences. And if autism itself wasn't enough with those differences in social interaction and communication and restrictive and repetitive behaviors, there's all kinds of co-occurring or comorbidities that go along with the disorder. The most common are GI concerns. I think about 40% have GI concerns. My Kaylee, for instance, has reflux, irritable bowel, and eosinophilic gastroenteritis is treated for all three of those. Many kids have constipation issues. She's also had that. Anxiety. And we find that the anxiety and the ADHD is a little bit more of a younger child thing, but certainly some of it follows them into adulthood. Kaylee just was a whirling dervish as a child. No matter all the great behavior tools that I had, she could just come into a room and I could just see what she was going to take out. And so you would grab and put a lot of things away to get them out of the way and not be. So you think about what you do in managing your sensory climate as much as you can for children encountering it. Some have cognitive deficits. Actually, a fair amount have seizure disorders. About 50% have sleep problems. And as you get a little bit older, a lot of them deal with depression and obsessions and compulsions, which if they have that restrictive and repetitive behavior as part of their diagnosis, they're going to have some of this. So our families deal with a lot, and there's a lot of day-to-day managing that just kind of keeps coming back all the time. So these are the things that all are part of what a lot of families deal with and what you'll see. Anxiety specifically, because it obviously could really affect, they talked about a child being anxious about your gear, certainly about the sirens, about the noises, all of that, of course. And so how do we lower that anxiety? Can we take the siren? Can we silence the siren? Can we get them into as quiet of a place as possible? Just like they talked about in the emergency department at Children's Mercy, we try and triage them into a quiet room rather than leave them out where the general public is, because they're often way overstimulated and very anxiety ridden with that. What we know is 11 to 84% of kids with the autism spectrum have an anxiety disorder, and that compares to the general public of 2.5 to 5% of children overall. So you can see it's much more prevalent in kids with autism spectrum disorder. Then there also can be panic disorders, separation anxiety. What we find is both behavior and medication combined are most effective in dealing with this. So maybe many of these kids you encounter will be on certain medications for that. And then we know, of course, that there's many psychiatric comorbidities. And certainly as kids get older and become adults, again, we find that a lot of these follow them. Here, significantly higher rates of co-occurring health conditions combined with communication deficits like our kids have create injury risks or, more potential for interaction with law enforcement and first responders. In fact, kids and children and adolescents with a autism spectrum disorder are about 10 times more likely to have an inpatient psychiatric state than their typical developing peers. And by the age of 21, how about this? 20% of young adults with autism spectrum disorder have had interactions with law enforcement. And what becomes really difficult about that is that sometimes the inability to make eye contact or to give verbal responses or things like that really make them suspect. And what we do know, though, and this is on a positive note, rates of violent criminal offenses are low with people with autism spectrum disorder for the most part. And so across the lifespan, this is what we see with children. We talked about behavior disorders, anxiety disorders. As the kids become older and get into adolescence, more depression and anxiety disorders seem to exist. The catatonia I can't speak to really specifically, but the depression is because by adolescence, if they're of more of a typical cognition, they understand that they're being left out. They understand that people aren't inviting them to things, that they aren't becoming a part of things. And then adults actually have much less research is done on them, but we do know that they have increased rates of mental health problems. And I hear this all the time, especially from my first responders that are police professionals. They talk about how many calls they do on mental health problems with people with autism and for the families that deal with them. I often say I am so grateful that Kaylee is 5'2" and 100 and what's she weighing? About 103 pounds right now, because we have kids that we see in our clinic and young adults that are 6'5" and 250 pounds. I'm telling you that 103-pound girl, I am strong, and she can just about outdo me in some cases. So just know that you're going to be better waiting them out, developing some good interaction with them by experience and a little bit of extra time rather than coming at them in any way to try and get done what you need to get done. So here's some more specifics. Know that they might be nonverbal or have limited speech, that they might avoid eye contact. You know how they showed in that video the lack of fear of real danger, that kiddo darting out into traffic. I am positive that my daughter would dart right, if we were on a freeway, got in an accident, she would dart right into no idea of what real danger. And I found that typical cognition kids that are higher functioning than her cognitively have the same lack of fear of real danger. So just know that you got to be really careful with them. They might display unusual responses to lights and sounds. We've talked about what we can do with that. If you can, minimize those sounds and those lights. Know that they may avoid or pull back or be overly sensitive to touch. We're going to have to develop some behavior momentum in dealing with that. And also know that they may have a delayed response to questions. What a lot of people say with autism is that they need to take something in and then they need to almost process it in their head. Even one of the most well-known autistic professionals out there, Temple Grandin, who is a doctor of veterinary medicine, says that when I've heard her speak several times, she said she has to take a question, she has to turn it into pictures in her head, and then she has to formulate the answer and then say it. And so all of that takes some processing time. So know that they might have delayed response to question. The other thing I want to point out is that when you saw that kiddo in the ambulance, several times the professional was using a visual icon that was saying, okay, or you're doing a good job. And that kiddo was rocking back and forth, but they said, are you hurt? Are you hurt? Do you hurt anywhere? And he said, no. Well, what I want to tell you is you can't go with that no, because that might not be the truth. So you have to do all the diagnostic stuff that you would normally do, because they could be hurt very bad and be saying, no, they're not hurt at all. So they're not good at, determining what is necessarily the accurate answer in situations like that. How to communicate. We've talked about being patient. I talk to my policemen all the time about making sure that they're unarmed and maintain a safe distance, because they may suddenly invade your space. That is so true. Different times they might rock back with their head. Again, they're not trying to be obstinate. They're just saying, you're invading my personal space and I'm trying to get away from you. We talk about talking calmly and softly, or in our clinic, we talk about going low and slow. Don't use an excited voice, use a calm voice, go slowly, might allow them to process a little bit better. But we do want you to speak in short and direct phrases. These are pragmatic thinkers. So stand up now. Please sit. You just don't need all that extraneous communication in between. And they don't understand certain idioms, such as, are you pulling my leg? Well, if you would say that to someone with autism, they literally would look at your leg and go, no. So tell them directly what you want them to do and allow for that delayed response. The best source that you possibly have is someone, a parent, a neighbor on the scene, or somebody that might know how to de-escalate their behavior. What calms them down? What can you do? How to communicate with them on that. And we talked about managing the sensory climate. So just, be aware of their self-protective responses, consider the impact of flashing lights, sirens. Again, don't try and stop that repetitive behavior unless there's a risk of an injury, and then be really aware of sudden invasion of your personal space. And so some de-escalation tips helpful in emergent situations or while securing for transport. So these are some specific things. What we want to look at is, this is kind of a MANT thing, but this is a colleague from KU that talks about, in a rage cycle, there's a rumbling, there's rage, and then there's recovery. Well, what you want to do is, in the rumbling, describe and praise things that they're doing right. And if they get to rage, no, you're not going to accomplish anything in that. It's not till you get to recovery that the work that you need to be done will be done. So you just don't try. If you try and come at them in rage, again, it's going to take longer. So if they're in just a full meltdown rage, you just have to allow some recovery time. Behavior is communication. People ask me all the time about my daughter. How do you know what she's feeling, what she's doing? I'm like, by her behavior. That is her language. And so you really want to be aware of a child or a young adult's behavior. It is communication. And here are the functions of behavior. Attention, so somebody's trying to get your attention. Somebody's trying to escape, to get out of something. This is the idea of them running off on a scene when we know it's dangerous for them. They might be trying to get something tangible, right? So here's the kiddo that wants the candy and somebody's not letting them get candy. So what's the function of the behavior? And then what makes them feel good and not as bad might be that sensory seeking or the self-stimulation. So all of this behavior has a function for them. It is their communication. So you have to think, what function is this particular communication? And how can we prevent escalation or further escalation? So, as positive of a relationship, even in the short term, as you can get with them, kind of think about front loading your efforts of, you're doing a nice job, good job. If you saw that guy going, good job, and just a lot of positive praise. Make several positive comments before making demands on someone, like, that's a nice shirt that you have on, or I like your hat, or just something that makes them know that maybe they have something special in their hand. A lot of them hold on to things. Just say, is that your favorite thing, or something like that. So lots of what we call describing and praising, and several positive before making demands. And again, you might have to increase that distance of safety physically and emotionally and psychologically for them. That's just kind of the way it rolls with people with autism spectrum disorder. A lot of questions, y'all. It is not going to work. A lot of times when people don't communicate well, people keep firing questions. Well, what about this? What about this? Do you hurt? Are you feeling, is it hurting anywhere? Do you have pain? Is it on and on and on? Okay, too many questions. Less is more when you're talking with someone. And again, kind of go to that behavior and say, what are they doing? And remember, you've got to give them some processing time. So ask a question, give them time. I understand that you have to seek some information, but you just can't fire it at them. So also just know that sometimes you're going to have to help with the de-escalation, and sometimes a person might have a trigger that you need to just temporarily remove. So let me give you an example of this. My daughter, for some reason right now, when she's frustrated, she grabs something and puts it in her mouth, and then she often can rip at it or do something like that. Well, for some reason that sets her off. If I get that out of her mouth, out of her hand, the escalation stops. In the shower, I shower with her because she needs complete support in that. And she grabs the hose and she puts that in her mouth. Well, I find if I put her to the back of the shower and take the hose and let it out of her hand, the de-escalation begins. She stops getting so angry. So sometimes you have to think about removing the trigger. It might be the place that you're triaging them. Maybe it's too loud. So we do a lot of redirecting. We do some distraction. I would say, oh, I didn't bring it with me, but I'm going to show you an example on another slide of some things you can do to distract. You might have some fidgets. You might have a weighted blanket. You might have a spinny toy that they can look at. All these things can serve as distractions and sometimes real help on scene. And then, just inviting them to de-escalate, just listening to them and inviting them to de-escalate. So can you calm down? I like how calm you're being right now. I like how you're getting calmer. So again, positive stuff. So communicate clearly what they need to do So pictures and gestures, it doesn't always have to be words. A lot of time, if you want them to sit down, just show them where you want them to sit. And then you could always potentially have some visual supports like the icons that you saw. Talk less, engage in neutral behavior, and try and get some behavior momentum. How I would describe that on scene would be something like, of course, you're not going to do a blood draw first, right? Let's do a pulse ox. Let's do a, pulse. Let's do, just a general visual exam before we would do a blood draw, before we would do a blood pressure, because these are things that can be increasingly sensory, putting off. So think about developing some behavior momentum and how to get compliance. Don't use a question, tell them what you'd like them to do. Not, can you sit down? Sit down, please. Get in as close proximity to them as you can and use a quiet voice. Look the person in the eye, but know that they might not look you back in the eye, but address them and then give them some processing time. Don't give multiple requests. Describe the behavior you want and be non-emotional. We say make more start requests than stop. So again, nice job with your hands rather than stop moving your hands. So more start than stop, and then just a lot of verbal reinforcement. So here are some specifics for emergency situations, because I want to leave time for your questions too. Some individuals with autism do not have that normal range of sensation. I talked about how they have often a very high pain tolerance, and even with specific pathology present, they may not say they're in pain, or they may deny pain. And beyond that, sometimes they have a really weird response to pain. My daughter will often laugh when she's hurt, and it's kind of a laugh and then she goes to a crying. I've heard kids that hum, that sing, that want to take off their clothes. Kaylee will take off her clothes occasionally too, but again, they may do some really strange things that don't look like hurt. Often, again, they have tactile issues. So, for instance, my daughter, a Band-Aid and other adhesives may greatly increase anxiety and aggression. Again, think of those pragmatic thinkers. A Band-Aid does not belong on her finger, so she rips it right off. I mean, we kind of hope and pray that if she's hurt herself, it can be stitched, because she typically can't get that off. But a Band-Aid or a bandage of any sort, she just pulls off because it doesn't make sense to her. So just know, we love Coban because we can do that, and then usually we can cover it up, and it's also very hard to get off. So just know I say she's like, they're often like little Houdinis. They can get things off. So you've got to really pull out some of your best skills and expect the unexpected. We've already talked about. So, few words as possible, and know that they might not respond to the Wong-Baker pain scale because they don't understand what those faces mean. They don't understand. Best person you could get as a caregiver for functional level, what might help? So like, even though Kaylee's 27 years old, stickers or stuffed animals might calm and help her. And so just know that, sometimes unsuspecting things might help. Again, a fidget, something that distracts them. Attempt to perform exams in a quiet spot, as quiet as possible. Move slowly from distal to proximal. That's going to be your very best bet. And know that, again, they have a hard time reading that facial expression. Adults with autism have increased rates of medical comorbidities, like we talked about. So for almost every organ system, and reduced, sadly, they have reduced healthcare access. That's a long topic in itself, and then often worse health outcomes. But all of these factors increase the likelihood of you encountering them in an emergency medical situation, like what you work in every day. So just know that these are some special things we have to take under consideration. Enrage, I think we've talked enough about this, removing triggers, accessing the environment. Just know that sometimes you need some backup help, a number of individuals, and be prepared to take time. And you might, need to have multiple attempts at, resoluting behavior. So just know it's going to take time. And you just have to wait until de-escalation occurs, so you won't be effective until then. And so just a reminder about that. Here's some things that might help. I think these are things that are kind of easy to have maybe on the emergency vehicle. Fidgets that they could play with. Right now we have to clean everything and do all that, but that's a spinny toy on the right. It'd be something that you get at the circus or the ice show or Disneyland or something like that, and it goes lights, and it can really be distracting and engaging for some people with autism. Our child life people at Children's Mercy use that a lot with kids with autism. The one in the middle is a weighted blanket. 20 pounds is not necessary. It was just part of the thing that I took off the web, but the idea that sometimes a weighted blanket, or sometimes we even have like weighted lap pads for different procedures and things like that. You have to be careful about the percentage of weight to the weight of the person, but they really can be very calming for people, as can something like the fidget on the left of the screen. We all have our own biases, and when you think of the word autism, what we often think of is the cute little Caucasian male, but, really autism is a very diverse community. We have all races, all ethnicities, different gender identities, different sexual orientation, different verbal ability. So really, just like every community, they are a representation of everyone. And so don't just think in narrow terms, think of a more diverse community. And we also talk about the risk for negative outcomes during a crisis interaction by those, to do with racial and ethnic minorities. Gosh, I have, again, a friend who's African American, has a son that is 6'5", about 225, 230 pounds, and nonverbal. And she says, and as did this father of a Black teen with autism, that they're so worried about how they come off, and understand that just in being them, it makes it scary for them. So, we all have to kind of work together to understand better what some of the difficulties and some of the challenges are for families like ours. And then an estimated 20% of individuals, which is the general public, is about 5% of what we call neurotypical individuals, identify as LGBT. Well, 20% of people with ASD do. So it's just good to know, but we also know that they increase the risk for victimization and discrimination of them. And then this final, just a reminder on this known safety risk of accidental drowning. So again, in 2009 to 2011, it was 91% of deaths of kids with autism, 14 and younger. What we say to families is, please, please, please teach your kids how to swim. Please get them into swimming lessons, because typically, that can help with this possibility of accidental drowning. But if a kiddo has gone, or an adult has eloped and is unable to be found, go to the bodies of water first. They can have other dangerous attractions. Some love roadways, some love trains, some love, I've heard, traffic signals, water towers, the whole 9 yards. So you just have to know that, everything's a possibility. So now's the time for questions, and I say there's no question off the board, so please use it as a time. And I've just gone to some of my references here. I just hope, and what I'd also like to put out to you is, get to know somebody with autism. They're just really some special things to understand about them, and they really bring, rather than what I what I dislike about talking about all the negative things is that you don't get to talk about some of the really special things about them. And so I just would say, you know, if you have a chance to learn a little bit more, spend a little bit more time with somebody with autism spectrum disorder, help a family out, mentor a kiddo, gosh, it would be great for all of us. We just all have to build capacity together. It's been very difficult time in COVID for our families because our kids' world has narrowed so drastically, like all of us, but they have had a really hard time understanding it because it's been so different from all the rest of their lives. So, and I'm sure for all of us, it's been a difficult time. So with that, I'm just going to say thank you so much for taking the time to learn. I hope I've given you some real practical tips on things that you can do that might make your job a little bit easier. And with that, I will stop for questions. I'm going to escape and I'm going to stop sharing. And I think I can answer questions.
First of all, thank you, Marianne. That was super, super informative. That was great. So just, again, we really appreciate you presenting all of that. So we've got a lot of questions coming in, so I'm just going to dive in so we can get to as many as possible.
Great.
One question here, someone has a nephew who's autistic. At what age do, most children kind of, and I know it's going to vary, but do they first start showing some of the signs of autism?
Ooh, great question. Sometimes as early as before a year of age. So we start some of our diagnosing in our clinics. There is, believe it or not, there's 2 types of tests that we use, and they go through several different standardized tests for diagnosis. But we have one that's for more infants and then one that's for toddlers. And so especially if there is somebody in their family that has autism, like on the next kiddo, if even before a year they show signs, we say try and get them in to be evaluated, because the sooner we can get, if there is a diagnosis, if they meet criteria, the sooner we can get to early interventions and things like that, the more successful we are. So sometimes even before a year of age.
And towards the beginning, you'd mentioned, restrictive behavior being used with children. This person just wanted a little bit of clarification about kind of what that is and kind of some, I guess, what are some good alternatives as well?
Yeah, well, you might play to those strengths. So let's say the example of the kiddo, it's a good question, the kiddo that is really into clocks. If it's something that you know about them and they're just taken with it, you might use that as a little bit of a tease for something like to get their attention, so that while at the same time somebody else might be doing something that they need to be doing with them. So a distraction technique. It's hard to say because every kiddo has kind of something different, but the whole restrictive thing is just, it just more affects things like let's say a kiddo really insists on going the same way to school every day. So so what does that mean? Well, that means detours can really throw them off for the day. That means somebody wanting to take a different route to the same place can really make them crazy. So that's more what I'm saying about restrictive or repetitive. It doesn't always deal so much with an emergency situation, but a day-to-day living situation.
Gotcha. Thank you. As far as pain management and sedation for these patients, this can be really challenging as far as, diagnosing even what level of pain they're in. So do you have any recommendations on how to assess and treat that?
Oh, great question. That is very, very difficult. But I will just say in my experience with Kaylee, she's had lots of procedures. She's had some surgeries. They typically, even as a 2-year-old with her first head CT scan that she had, I remember them saying to me, she needed a lot of sedation. Mm-hmm. We needed a lot to get her under. So just know that maybe in some instances it's going to take more than the average. And I would say err on the side of making them as comfortable as you possibly can, because they're unable sometimes to tell you, how they're feeling accurately. Mm-hmm. That's a very hard one. Very hard.
Mm-hmm. This one goes backtracking a little bit to diagnosis. This person said they'd heard before that girls can actually be a little bit harder to diagnose. Is that something that you've heard?
That is true. Okay. And you know why? Girls are a little more social. Just in general, we kind of beat the guys on the socialization. So a lot of times, like I will tell you, even with my Kaylee, she was originally looked at the team when she was like, I'm going to say 2 years and 7 months. And she was a little too social, a little too interactive. They couldn't give her the diagnosis. She was still nonverbal and everything. So it actually, was seen again at almost 9 years of age and then given the diagnosis because she had lost communication. She had kind of gone into herself. She lost some of that socialization. So it's true. Girls, even impaired girls, pick up socialization and typically do it better than boys in the younger developmental stages. So yes, sometimes that tricks us into knowing whether or not they actually meet criteria. Really good question.
And then here's one I'm getting a lot. Some agencies have said they have stickers. Others would really like to have access to those stickers that can be placed in the like windows, like you mentioned, alerting law enforcement that there's a child with autism in this vehicle. Mm-hmm. They didn't know. A lot of them aren't sure where in their communities to reach out to. Do you know? Like,
hey, you know what? I wish you guys would all get together. You 6 states, and you develop one. And here's what I want to ask you, because the one on my car says a special needs person is in this car and may not respond to verbal commands. Well, you know what? Let's use people first language. Mm-hmm. Let's say a person with special needs is in this vehicle and may not respond to verbal commands rather than a special needs person. We really like the person to be identified first. It's called people first language rather than the disability. So I think, I'll tell you, I got one recent, I got the one that I have on my car from our county, but I've gone to Etsy and I've asked them to do them for us for Children's Mercy with people first language. And I hope that it's something, we're not seeing quite as many families now because of a lot of stuff being virtual, but I hope that it's something we can do in the future. But I think it would be a fabulous idea for your coalition to do that. And wouldn't it be helpful if we knew coming onto a vehicle that person had, absolutely. And then also, I hope that you have some information in the emergency system, whether it's a 911 system, on what that looks like for that kid so that the parent has spelled out. So for instance, in my life, now my Kaylee has been back home during COVID. She was in a group home for a small time, but she's back home because she got so bad. She sleeps in a bedroom in the southwest corner of our house. The fire department knows that. We lock her door from the hallway, otherwise she would wander at night. So instead of her locking from the inside, it's locked from the outside. So just specifics like that, give them some sort of an opportunity to provide you with all the information you need.
That's good. And then I've got another person here who followed up with that and asked if you've seen or have any recommendations on, and this is something I've heard about a little bit for other disorders too. So not just the, like the stickers, but having seatbelt covers too.
I can't. Yes. And if they go to that big red safety toolkit that I put on the end of the thing, mm-hmm. If they're still sending those out, that can really help. So again, they can be little Houdinis. Kaylee, this is a new skill that she can get out of her seatbelt. She did it as a kiddo because she was like a Gumby doll. She had such low tone, she could slide down anything. But we've had so many special seats. But just in COVID, she's figured out how to undo her. Never before at 27, she figured out how to undo it. So we've had to do all kinds of things with the seatbelt, one being a lock on it so she can't get out. So yes, great idea for families to get that. Super great idea.
And then you mentioned, how, COVID's really impacted your daughter, and I'm sure a lot of other, all sorts of children and adults with us.
Right.
I've got a comment here from someone who works in the school and kind of, clicked with something you mentioned that, because of COVID, a lot of people's daily rituals and repetitions have been disrupted, and that's,
yes.
Very important. Do you have any recommendations to kind of help get these kids back on track as far as, trying to adjust into that new normal and make those, rituals and routines a little bit more a part of this different kind of day?
I think in any way, I just can't wait. I just can't wait until I just say, I feel like so much of Kaylee's angst was that her world went from very involved to incredibly narrow, with no understanding of why that happened and why it happened. And so I think, get your vaccine. Hopefully all of you have gotten it with the work that you do. Encourage people to get theirs. Tell them it's safe. Tell them it's been more well studied than any other vaccine that we have ever had. And so I think that I think this is what's going to help. I think once enough people feel comfortable, get the vaccine, allow the world to open up a little bit more, I think our population will be so much better off. Having said that, I'm a little bit worried how re-entry is going to be, because again, they're so routine driven that routine has been completely upended. So we all might have to have a little bit of grace as we come back into the world with these kids. I mean, I'm thinking we haven't even gone to church. She hasn't missed a Sunday of church in her life, and now it's been a year and we haven't been able to go because she won't keep a mask on. So I think we're all going to have to have a lot of grace, but I think the number one thing would be tell people to do what they can to be safe before they get the vaccine, and then please get the vaccine. I think as medical professionals, your voice is so important out there in the world for telling people the value of that. And I think that's eventually what's going to get us all back to, some new semblance of typical. Good question.
Well, this next one ties right in with vaccines. This person has a son who is scared of needles, is on the spectrum, and has several other conditions. What's a great way to help these kids, who have, maybe some hypersensory, issues, and then, throw needles into the mix?
Yeah, so we do a little bit. If you go on Children's Mercy website, we have now implemented, I forget the tagline for this thing, but like, for instance, for all kids, we use like a Buzzy Bee, or we do a topical for shots and things like that. So that might work. Again, some distraction techniques and just showing them, how it's going to be. And it just takes a second and you'll be really quick. I mean, interestingly enough, Kaylee she doesn't go, I mean, she was just, they're like, she's the best one we've had so far. I'm like, I know, she's tough as nails. So some are really sensitive, but some are just, I mean, also the COVID test, she's had to be tested for COVID several times. Now she's fully vaccinated, but they're literally, the nurse said to me in the drive-through, I've never had somebody be so good. I'm like, I know. Because she, that pain sensation is different for her. But I think that, there are some techniques with making a topical or using like a Buzzy Bee or a distraction spinny toy or something like that might help the moment. But it does kind of hurt. It hurts worse afterwards, right? But it does kind of hurt, but not as bad as a flu shot, I thought. So, we'll see.
Right, and this will be our last one.
Okay.
So for all the ones that we haven't answered, guys, we'll follow up with those. But what is, in your work, what you've seen the biggest myth about, people with autism, and, what would you like to, succinctly say to kind of, bust that myth?
I love it. Don't ever say what they can't do. Focus on what they can do. Go play to their strengths. And, I tell my doctors, don't ever say, well, they'll never be able to do that, or they'll never be able to do that, because we have no idea. Even as kids grow up, even the kids like Kaylee Hammond that are super restrictive cognitively wise, you know what? She's still learning new things. She's still learning how to do things. So don't limit what they can do. And the other idea is make them part of everything rather than singling them out or saying that they have this or they have that. Bring them into the fold, play to their strengths, and find out a little bit more about them. And I think by just building capacity in general in the world, we will all be better off, because what we find, let's say in employment and things like that, is that some of these kids that have a propensity to be great with numbers and things like that, well, the lack of socialization actually makes them a very good employee. They're not going to be at the water cooler, spreading rumors, or they're very, very vigilant about being on time and doing things just in a set fashion. So for certain things, some of the idiosyncrasies of autism can really play to a strength. And that's what we have to think of. What are some of their gifts rather than what are simply their deficits? So I love that question.
Well, again, thank you so much, Marianne. I think we've, as from I've seen in the comments, I think we've all learned a lot. So we really appreciate your time tonight. And thank you for sharing everything with us.
Great. And if you have any questions, for sure, forward those to me. I'll be happy to get back to anybody on anything, and be more than happy if there was things that we didn't cover. So thanks so much for the chance.
Yeah, of course. Absolutely. Okay. All righty then. To kind of keep us on schedule tonight, guys, we're going to go ahead and move right into our next presenter. So we're going to be talking with Dr. Kristilynn Cedars. She's going to be teaching us about traumatic stress in children and how to respond in the field to kind of help mitigate this. Dr. Cedars is a clinical psychologist who specializes in pediatrics, and she actually works with infants and families during their admission to the NICU to help minimize the trauma and help them cope with the stress, anxiety, and just other difficult emotions that come with this adjustment. So Dr. Cedars, thank you so much for being here. Welcome. And I'm going to turn things over to you now.
Sounds great. Thank you so much, everyone. I'm going to try to screen share here and hope this works like I want it to. Here we go. Perfect. There we go. So I caught just the end of your previous presentation on a lot of autism spectrum behavior. So I threw just a tiny bit in there. So hopefully it's not too much of a repeat as we talk about child development and things like that. But like Brittany said, I am a clinical psychologist and currently at Children's Hospital in Fargo, North Dakota. And I want to spend a little bit of time talking about trauma and how to help mitigate the impact of trauma on our kids, both kind of in the moment in the field, as well as they get to the hospital and beyond that time frame. I have no financial disclosures. You probably saw these objectives on your handouts and things like that. So we are going to talk a little bit about basic child development, just because it's so important to sort of understand and meet a kid where they're at if we're going to try to understand how they respond to trauma and traumatic events. And so just to make sure everybody is sort of on the same page and level setting, we'll just kind of run through a little bit of basic child development and how some of those nuances do impact sort of how they understand traumatic experiences. Then we'll just kind of quickly review what are some of the ways that kids express trauma at different age groups, because kids are not miniature adults. They do not respond in the same ways that we do to difficult situations. So we need to kind of know what we're looking for in each age group and what we need to pay attention to. And then we'll talk about like, what are our tools to mitigate stress in the moment? And I'm going to just give you a little brief introduction to psychological first aid as sort of the evidence-based way to provide good care kind of in the moment to help reduce the impact of traumatic stress on patients and families, or kids and families. So development matters. Obviously, having just had a talk about autism spectrum disorders, that developmental piece is huge, and understanding that chronological age does not equal developmental age is a huge piece of that. So you can't judge someone's ability to understand what you're saying to them, their emotional development, their cognitive development, their language development by just looking at them. It takes a little longer than that. And I heard you guys sort of in the questions talking about the best ways to sort of identify autism spectrum youth or youth with significant developmental issues, and window stickers and other things, because that information is so important in the work that you all do kind of in a crisis situation. So in trying to gauge their development, you always want to sort of ask yourself, you know, what's age appropriate and what do I think the child is hearing? Because we all know that sometimes the message that we send as a communicator is not the message that is received. And that is particularly true when people are under stress. They filter everything through their experience, through their emotional lens. And so that doesn't mean that they are always hearing exactly what we are saying. So just kind of thinking about development in that sort of infancy stage up till 2 years old. These kids are sensory explorers. They are really learning about their world through all of their senses. And this is why young kids put lots of things in their mouths. They touch everything. They want to explore their world. That's how they understand the world. This time frame is really critical for attachment. And so having a reliable caregiver is pivotal for good development. And so this is why we see kids who have significant abuse and neglect in this time frame sometimes go on to develop significant psychiatric symptoms and behavioral difficulties because they kind of didn't have that basic need as a young child. During this time frame, receptive language is better than expressive language, which just means that their ability to understand what you're saying to them is much better than their ability to talk to you. And obviously, as you go through this period, that receptive language starts to improve quite a bit from just early language things of understanding their name, knowing what the word no means, even if they don't listen to the word no, and things like that. Pretty early in development, babies should know their name and start to recognize their name, turn their head to their name, pay attention to their name if they're sort of typically developing. For these kids, things that are familiar are going to be calming. So familiar people, familiar objects, those kinds of things. So they're going to respond well to, soothing touch, rocking, shushing, distraction things. Most kids are captivated by lights and music and things like that. So those are your sort of critical developmental things in this early age group. When we start to look at our preschoolers and toddlers, we see that development of autonomy and independence. So which comes with it then for some kids, temper tantrums or mini meltdowns, things like that, because they are trying to understand what they have control over in the world and what they don't have control over. They are still in that boat of their receptive vocabulary being better than their expressive vocabulary. But towards the end of this period, they're starting to have much better expressive vocabulary, but their ability to express emotions still is not, or I shouldn't say express emotions, I should say understand and articulate what their emotions are is still not very good. They sort of are at a couple basic emotions. Kids in this age group have excellent imaginations. It's one of their amazing strengths. But with that can come a period that really leaves them at risk for anxiety because they have a limited ability to distinguish what's real and what's not real. So if you are playing in your room all day and there's no monsters in your room and everything is fine, and when you turn off the lights, if the pile of laundry in the corner looks like a monster coming up out of the swamp, they aren't able to do that sort of, okay, so if when the lights are on, it's closed, and when I turn the lights off, it's probably still closed. Like they aren't able to make that leap because that line between reality and fantasy isn't very clear. And so it leaves kids at risk for sort of anxious reactions at this age. They also have a lot of magical thinking. They don't really understand very well clear cause and effect. And that magical thinking can work to our favor sometimes in our interventions that we can use. Like with kids who are afraid to go to bed, we have magical monster spray, which is, just lemon scented water. And that gives them that sense of control and they feel good about that. And that works great. But magical thinking also sort of can lead them to sort of believe that they caused an accident or that they are responsible for something that they are not responsible for, or that somebody can come back from the dead because they don't really understand that. And, TV and other things don't exactly do a great job of portraying accurate things around death. And so kids' magical thinking can kind of impact their experience of trauma. And then, like I said, they really sort of in this early age group just have sort of three basic emotions. As you start to move towards the end of this age group, that emotional IQ starts to expand beyond sort of happy, sad, mad, starts to include fear and some other emotions as we get into that school age group. So our school agers for our definition here are somewhere in that sort of 1st to 6th grade age group. This age group, all of these things are sort of increasing over time and are more prevalent towards the end, less prevalent at the beginning of this age group. But they have increasing ability to use logic. So, start to understand that cause and effect, be able to do the sort of if then type thinking. You do this, then you get this. That is much better at this age group. Some preschoolers can do it pretty well, but others, they're not very good at waiting for things. Waiting for rewards is a thing that in a young age group, you got to sort of give rewards, give praise right away. School agers start to increase their ability to kind of wait for those things. But this age group still is pretty concrete in their thinking. They have a hard time wrapping their brain around abstract things. They can still be pretty black and white. Things are either right or they are wrong, those kinds of things. And so sometimes with accidents and injuries or bad things happening, it's very hard for them to understand. But if I was good, if I did something good, why did something bad happen to me? Because that sort of black and white thinking kind of impairs their ability to sort of unfortunately realize that bad things can happen to good people. In this age group can be a lot of fun because they do start to understand humor, kind of basic humor at the beginning, knock jokes, things like that, and more complex up to sort of sarcasm as they get to the end of this age group. Humor can be a wonderful tool for some kids to cope. It can be a really good distraction if they're into the sort of little humor and jokes and riddles and things like that. So it's a tool you can have in your tool belt to kind of distract them in the moment if you need it. Like I said, their emotions, ability to sort of know what their emotions are in themselves. So identify their emotions, understand their emotions, and then be able to talk about their emotions really improves over this time period, which is so helpful for us when we do sort of trauma work, because really part of that is understanding your emotional reactions to something that has happened. During this age group, we also have an ability to sort of take perspective. They understand now how others see them, how others see the world, and even how others sort of judge them. And they are starting to become more accurate judges of their own strengths and weaknesses, which young kids don't have. If you've ever been around a preschooler, they are all the fastest runner, the highest jumper, the best drawer, whatever it is. And that's actually a really protective skill because, as we know in truth, they are not the best at everything, but that helps them develop good self-esteem to have that sort of belief. But during the school age years, that switches in that they are now able to judge their own strengths and weaknesses. And what happens then is you can see the development of the understanding of the emotion of embarrassment and sort of understanding like when they do something that someone else thinks is funny or whatever that might be. And you can also see the beginnings of social anxiety take hold, because if they're very worried about how other people are judging them, then they may become very anxious in social situations. In adolescent years, so adolescents have the ability to be logical. Now, that doesn't mean that they always are very good at using logic, or they can use logic to their favor and choose to ignore it when it's not to their benefit, but they have that ability. They also start to have skills for sort of abstract thinking and hypothetical thinking. And again, that doesn't mean they always use it, but they can understand sort of abstract principles. Again, in this age group, you see that defiance sort of similar to when they were toddlers and early preschoolers, because they're trying to develop their sense of identity, who they are separate from their family of origin, separate from, their friends, and how they're similar to their friends, how they're different from their friends, and how they fit in is so important to them in this age group. When we think about adolescents, we know that while they can understand abstract things and wait for rewards and stuff, they are very poor at factoring in long-term consequences. Because they can mentally understand them, but they don't mean much to them, and that it doesn't really change their behavior all that much. They are much more sort of still immediate focused, immediate driven. Lots of adolescents sort of filter in this world of that they are sort of invincible and bad things don't happen to them. So they can tell you, why people should wear their seatbelts, why they should follow the speed limit, why they shouldn't drink and drive. They understand the consequences of those behaviors, but they don't judge the risk to really apply to them all that much, which is what feeds into some of their risk-taking behaviors, is because there's sort of this invincibility component to it. And there's also this sort of self-centered nature to adolescents, in that they all sort of think that they are the center of attention for everyone. But the sort of ironic truth is they're all dancing on their own stage in their own spotlight and very focused on themselves and not so much on anybody else. But they believe that everyone else is sort of microanalyzing everything that they do and paying attention to everything that they do. And as time goes on, more and more of the literature into brain development, cognitive development, just child development in general, sort of extends the age of adolescence to 25 and even beyond that in terms of that executive functioning development, which is your sort of problem solving and things like that. Some people even say into 30 or beyond, depending on life circumstances. And so the idea that kids are an adult at 18 is legally true, but there is not a magic change that happens within their brain when they turn 18 that suddenly makes them think like a fully functioning adult. So sometimes we really have to, as we're trying to wrap our head around why teenagers do things sometimes, is remembering that maybe they're not quite fully developed yet. And on that note, as we sort of talk about adolescent brain development, I think it's so important to kind of note that the adolescent brain is sort of like a giant construction zone during these years. The brain, generally speaking, develops in a pattern from back to front, with this front part right behind your forehead developing last. That's your prefrontal cortex. And it controls really important things: impulse control, complex decision-making, planning, emotional reactions, attention, all of those sort of executive functions, those things that really sort of make you hopefully an adult. And as the brain is sort of finishing up its development in late adolescence, one of the things it needs to do is it needs to become more efficient, which means it starts to cut all these unnecessary brain connections, like the 12 different ways to do things or to get to different things. And when the brain is doing that, it's almost like that section of the brain goes offline. So a skill they had or something they were doing really well for a long time might suddenly be sort of like you're talking to a brick wall again, and you're like, oh my God, you've known this forever. Why are we going over this again and again? Or why are we crossing this bridge again? It's probably because that part of the brain is sort of not connected currently. It's going through its pruning process. It's trying to become more efficient. It will come back online. You just got to give it time. You got to give it patience. And this is why, as much as adolescents want a lot of freedom, they still need a lot of oversight in these adolescent years. Especially in my world, we think about like medication adherence, ability to follow through on complex medical regimens, things like that. Yes, they have the knowledge to be able to do that at this period, but they don't always have the tools that they need functioning. And so we have to continue to watch these things, or we will see them do poorly, have health consequences, things like that. So I know this is the part where we might be overlapping a little. I just want to make a note on sort of that autism spectrum disorder. It sounds like you guys got a wonderful presentation right before this with a lot more on sort of that autism spectrum disorder. I think the thing that's important to remember is a lot of people might be familiar with old diagnostic labels like Asperger's disorder and some of the other things. Is under the DSM-5, which is the sort of diagnostic manual for mental health providers. The newest version, which came out probably 8 years ago now, moved away from these separate developmental disability diagnoses into one bigger spectrum for autism spectrum. And so you might look at some kids who, have, quote, an autism spectrum diagnosis, and it's not really what you are sort of expecting. It's because it's such a big spectrum, we don't really know. It doesn't fit our stereotypes anymore. And so just remembering that it's that broad spectrum, that it could be a wide variety of behaviors displayed, a wide variety of strengths and weaknesses. It's important to be able to identify these kids in your line of work. So what is the impact of trauma on kids? What are we looking for is what we're sort of going to move into next, since we've sort of at least hopefully leveled the playing field a little bit on child development. Like I said earlier, reactions vary greatly. And the thing about trauma on kids is some kids are going to have immediate reactions that are going to make you concerned for them. And others are going to have completely delayed reactions. They're going to look like they are coping just fine, no concerns, you're feeling great about how things are going, and those reactions may pop up later. And of those kids that have the initial reactions, some of those reactions are going to sort of peak and go down by themselves and get better all by themselves without a whole lot of intervention. They're just very normal reactions to trauma. Others are going to persist and, you know, continue on for a long time. I often tell families when I first meet them after a major traumatic experience in the hospital that sort of any feelings they are having at that moment is probably very normal. Now, that doesn't mean that those reactions are distressing and that we can't provide some tools to help them, but whatever they're having, whatever reaction they're having is pretty normal, because intense fear, disbelief, feeling numb, feeling overwhelmed, those are all very reasonable reactions to a very scary experience. So we want to help them understand that it's okay to feel these things. These things are normal. Now, like I said, that doesn't mean we can't help them in some way, but they are very normal. And for some families, that's very reassuring. I think for a lot of parents, the first day after they see a traumatic experience, when they close their eyes at night, that's all they see and they don't sleep. And I always tell them, that's the worst night. You just got through the worst night probably. Tomorrow or the next day, you're going to be exhausted. It's going to be a little bit better. And that picture won't always be there. And that's true for a lot of people. There will be people who will go on to develop post-traumatic stress disorder and have that sort of flashback experience. But by and large, it's a very normal experience right out of the gate. When we think about trauma impacting kids and who's at most risk, there are sort of things that increase a child's vulnerability to trauma. Pre-existing mental health conditions and previous trauma exposure are your two biggest vulnerabilities that kids have. I'm sure many of you have heard of the studies around ACEs or serious adverse childhood events. The more of those you have, the greater your risk for traumatic stress. So when we think about kids under 5, what are we looking for that might be reactions to trauma? So these kids might be more clingy to their parent or caregiver. They might have a really hard time with separation, especially if they are in a novel environment like a hospital. So a completely normal and expected reaction. But again, what we expect is that as they go back to their environment, they settle in a little bit, this gets better. If it persists, that's when we sort of are really concerned about that traumatic stress reaction. They might not be able to express fear. Kids use crying to communicate many of their emotions early on in life. They use it to communicate their emotional states as well as their physical states as well as their emotions. And so you're looking at that facial expression for signs of fear, for signs of pain. Kids like this may sort of whimper or tremble in the corner. They may sort of just move aimlessly about, appear lost, kind of be wandering around, almost like they're kind of in shock or a little bit numb. Some kids, when faced with trauma, will freeze. And for kids who have been in severe abusive situations, sometimes this is very functional for them, because if they freeze and try to kind of become invisible, maybe somebody leaves them alone or doesn't notice them that time. And so that can be a really common sort of stress response. But if kids that do this will start to freeze at every little minor stressor rather than just things where it might be really appropriate, that sort of fight or flight response. And then the other thing we really tell parents to watch for in this young thing is regression in some skill that they had already developed. So maybe they had stopped sucking their thumb, or they had been doing really good at potty training, and now suddenly we're kind of back a few steps. And what I always tell families is it'll come back. We just have to give it some time, in that their brain is doing work processing something else. So doing the work to do that new thing or that new behavior, it just doesn't have the capacity to do all of that at one time. So as you get into that sort of school age group, what are we looking for kids? The biggest sort of things are major changes in their mood or behaviors. So if kids were really social before and suddenly they don't want to go out with their friends, they're isolating themselves, they're not wanting to spend time with family, they're not wanting to do the things they used to like to do, that's a concern. That's a big change in behavior. It's a warning sign for depression, also a warning sign for trauma. You know, if they were typically outgoing and talkative and suddenly become very quiet, don't talk to family and friends, they're withdrawn, again, that raises that red flag that they're having some symptoms of trauma. Sleep problems and nightmares are a big one. Sometimes kids in this age group will have that minor behavioral regression of wanting to sleep with mom and dad, especially if they've struggled to sleep alone initially. And it's hard when you're sleeping alone at night. Lots of kids have nighttime fears. And so you'll see a little backward slide in that. Some nightmares or dreams are somewhat common, especially in the early weeks, because it is part of how our brain processes experiences. But if those nightmares become significant and intrusive, start to impact a child's desire or willingness to even go to sleep, like they're afraid to go to sleep because they don't want to have the bad dream, that's when we start to get really concerned. And I always tell parents that the nightmares don't have to be an exact sort of play out of the accident or whatever it was that happened to them, the traumatic experience. Sometimes they can be thematically related. So they're about something bad happening to them or something bad happening to people that they love. They're about danger or being chased, those kinds of things. And, you know, they're happening 2 or 3 times a week. They're distressing. That's when we're really concerned. Lots of kids in the hospital in the early days will tell me if they have memory for whatever happened to them, will tell me they have a dream or two. And like I said, I don't get worried about that. It's when they become persistent. Some kids will become much more irritable or sort of have some disruptive behaviors, not follow directions, break rules, get into fights. Another way kids express stress is through physical symptoms. So emotions like fear and anxiety and sort of being worried about the world not being safe anymore are really complex emotions, and they're really difficult for young kids to understand and be able to articulate. And so sometimes the brain does this unconscious thing where it takes those really difficult and complex emotions and basically converts them into physical symptoms, because we understand physical symptoms. We have a template for dealing with physical symptoms. When we have a headache, we get Tylenol, or we lay down, or we snuggle with mom for a while, or those kinds of things. We have a way of dealing with that, and our body understands that, and people also respect that. So you get to take a break maybe from some of the things that might be causing increased stress and are overwhelming. And so watching for new onset headaches, stomach aches, or other sources of chronic pain are really potential red flags for trauma symptoms in kids. Some kids will have school refusal. That can be because of anxiety or difficulty sort of managing that social situation. It can be due to fear of separation from parents. So if they were separated from their parents during an accident or didn't know where their parent was, that can be really traumatizing and can lead to significant school refusal. And so there's lots of strategies for managing that, which I will get into probably a little later. Lots of kids in this, one of the things we're at risk for is sort of developing, quote, unfounded fears, which is a difficult thing. So things they were used to be fine with, or you don't need to be afraid of, or things that are just sort of really unlikely to happen. So becoming terrified of tornadoes or hurricanes in the Midwest or whatever it might be. We're looking for symptoms of depression and kids that are filled with guilt. Because remember, we talked about how in this age group, they might believe they caused something to happen through their thoughts or through their negative behaviors. And so they may have a lot of guilt about that or think it's their fault. Some kids will just be sort of emotionally numb. And at first we might think, oh, they're doing this really great job handling it. But then it becomes clear that they're not really handling it. They are completely avoiding it and unable to even process the event, the emotion, anything that goes with it. And that's concerning. And then finally, you might see with all these other things going on in their minds, they might not be able to concentrate as well. They might have difficulty performing in school. Grades might fall. They might be tired at school if they're not sleeping at night, falling asleep at school, all those kinds of things. So adolescence, it's sort of like all of those things that were in childhood could potentially be true for adolescents. Adolescents tend to report more of the sort of flashbacks for the event, sort of those re-experiencing moments where it's hard for them to distinguish that it's not happening again. So they feel the same intense emotions that they felt in that moment, and the same amount of danger in just thinking about it or talking about it or having this memory. And so because of that, they may go to extreme lengths to avoid reminders of the event. I have had patients who are willing to drive incredibly out of their way not to have to pass the scene of where their car accident was. Or some kids who won't even drive again or have a ton of trouble getting into a vehicle again after a car accident. Or they may not want to drive down a specific road or be with a specific person. Or some kids really struggle after their initial hospitalization if they have to come back for additional, planned surgeries or other hospital things. The hospital can be a very traumatic sort of trigger reminder for a lot of kids, and they can really struggle with that, and they will avoid medical care as a result if their parent lets them. Sometimes kids turn to drugs and alcohol and other things to try to forget or kind of self-medicate some of their symptoms, or they just start to kind of engage in more of those risky behaviors as a sort of way of acting out and are destructive. Again, these adolescents are prone to that sort of physical complaint thing too. Even for teenagers, some of these emotions and experiences are very difficult to wrap their brain around. And so the brain just says, I've got a way to handle this for you. We'll have pain, and that will give you a way to sort of take care of yourself. Again, nightmares and sleep problems, very common, that isolation, depression, anxiety. Suicidal thoughts are more common in adolescence. I think we have, in general, teen suicide is an epidemic in the United States and is a major problem. But kids who have had significant traumatic experiences, have PTSD, are at significantly increased risk for suicide. So we want to make sure we're screening and asking those questions in every point of care that these kids are at. Teenagers, again, are prone to that idea of feeling guilty about something. And some teenagers will go and have these thoughts of revenge too. Like they will want to right the wrong, fix what has happened to them or happened to their loved one. And that's a significant sort of sign of a traumatic stress or of traumatic stress. And so as we've looked at all of these sort of different ways that different age groups kind of respond to trauma, symptoms that we're looking for, I think it's important to put out there sort of what is post-traumatic stress disorder, or PTSD, as most people are calling it. And so when we think about the symptoms of PTSD, they sort of fall into these 4 categories. So you have some sort of avoidance. It could be emotional avoidance. It could be behavioral avoidance. So avoiding triggers, having trouble remembering things, not being willing to talk about the feelings or the event, or just that numbness, the zoning out, the sort of being very withdrawn. That's avoidance in some way. You have to have some sort of re-experiencing of the event. And again, that can be nightmares, it can be flashbacks, it can just be sudden feelings of being overwhelmed and panicked, the same feelings that you experienced during that traumatic experience. Or for young children, this often comes out in themes around their play. So kids' imaginative play will start to have these sort of repeating traumatic experiences. Somebody will die in a car, a car crash or something like that as part of their play. And that's their sort of way of sharing their re-experiencing with us. You have lots of negative emotion options there. Could be thoughts of death, preoccupation with death or dying, depression, blame, sadness, fear, anxiety, all of those, being embarrassed or ashamed. And then we have some sort of increased activation too. So that nervous system is sort of overprimed and over responding. So we have, it could be irritability, could be outbursts of anger and frustration, jumpiness, being on edge, startling easy. It could be those concentration things. So a variety of different things. And when we think of PTSD, obviously you have to have the traumatic event, but you don't have to be the person who just experiences the traumatic event. It could be events that you hear about, or it could be learning that something traumatic has happened to your loved one. So you can develop PTSD without being the actual person involved in the traumatic experience. I think we've seen this on a larger scale with some of our major national crises like 9/11. There was people who were traumatized by just watching the television coverage or having a loved one experience that. They weren't part of that event, but they experienced it in some way and still could develop PTSD. You can develop PTSD from one single trauma or from repeated exposure to sort of a repeating adverse event or a string of adverse events. You have to have your symptoms, some of these cluster of symptoms, the 4 different things there, for at least a month in order to be classified as post-traumatic stress disorder. And then these symptoms have to cause some sort of clinically significant distress or impairment in functioning to sort of fall into needing a diagnosis. If you have symptoms such as these that are impairing and clinically distressing, but have not been present for a month, but have persisted for more than 3 days, then we use the terminology acute stress disorder and provide similar treatments, but sort of have not considered it sort of post-traumatic stress yet. It's acute stress. So just to kind of take a second of why do we care about addressing trauma? I'm sure I'm preaching a little bit to the choir here, but there have been many studies in the last 10 to 15, 20 years on the long-term consequences of sort of childhood traumatic stress or childhood trauma. The study around ACEs really looked at some of this, and kids who experience persistent trauma at young ages have trouble developing trusting adult relationships or just relationships in general, connecting with people. Exposure to trauma and traumatic stress actually changes how the brain develops, which means it changes how the brain processes and regulates emotion and how it responds to stress. And so it may develop sort of an overactive stress response where it has no ability to sort of have gradations of response to stress. It just goes from 0 to like Mach 20 immediately. And it changes brain development. They have done a lot of studies around, fMRIs and PET scans of sort of kids who have experienced recurrent traumatic events and sort of kids who have been lucky and not experienced those things, and their brain actually looks very different. These kids tend to engage in high-risk social behaviors, high-risk behaviors, puts them at increased risk for future accidents and injuries. And then there has been long-term data to show that kids who have significant trauma experiences and untreated traumatic stress are at increased risk for significant chronic health conditions. And so they have a shortened lifespan. And so being able to identify and respond to and provide trauma-informed care not only matters for their immediate health and well-being, but also for their long-term health and well-being. And so what are some of our sort of, in my book, tips or tricks, things that we can do? So I think the first thing is remembering that our communication with kids is key and is going to impact how they understand what's happening to them, which is going to impact how they respond and their experiences and how they remember that event. And that makes a big difference in the development of traumatic stress symptoms in the future. So developmentally appropriate language, getting down on their level physically and being able to talk to them in a way that they understand and make sense to them, so that because things that are understood and predictable are less stressful. Trying to take a minute to build some rapport if you can, if that's asking questions about what they like and you are up on the hip toddler TV shows or preschool shows or whatever it is, the books kids are reading, what they like, what they don't like, the video games they're interested, whatever it is, some of those little pieces to build connection and build that trust and rapport are going to go a long way in helping a kid feel more comfortable and reduce anxiety and stress in the moment. Another thing with communication is, as adults, we love to give ambiguous messages, but kids need very clear, simple messages. And under times of stress, we need those even more. We need to stick with one-step commands, which means one thing at a time. It's not, I need you to stop moving. I need you to put your left hand over here. I need you to do this, and I need you to do this and this and this. They didn't hear any of it. They might have got the last one or the first one. So you need to do one step at a time, very simple things, and then state those instructions in a positive manner. And what I mean by that is tell them what they should be doing and not what they shouldn't be doing. So, don't wiggle is not particularly helpful because they don't know what they're supposed to be doing then. And in a scary new situation, that's difficult to do. So, I need you to hold still for this time, or I need you to put your hands here, or I need you to do whatever. So telling them what they should be doing instead of what they shouldn't be doing. And in that same situation, I would say never tell a kid not to cry. They're allowed to have their emotional reaction. And so telling them to stop doing that or not do that is not particularly helpful. When we're working with kids, it's really helpful to label our praise, which means say more than good job, good girl, good boy. We want to say, good job holding still. Good job, keeping your arm still while we put your IV in. Those kinds of things. So very specific things. So they know what they've done well and they know what they need to do more of. I think with kids, it's always important, and especially adolescents, to be truthful. I run into this a lot when I get into the hospital on Monday mornings after a horrible accident and somebody has passed away as a result of the accident. And people have not been truthful with that child or adolescent and told them something that isn't true. And now the psychologist comes in on Monday and we have to sort of fix that. Now, I'm not saying that means you have to tell them everything, but I think you don't want to tell an all-out straight-faced lie. It's okay to sidestep. It's okay to be a little bit of a politician and distract from that if you're not ready or able to give that answer. But we don't want to tell them something that we know to be untrue because it's not helpful for them to build trust and to trust helping persons in the future. And then I think the other so important thing to remember is that kids are always listening. And this is true if you are a parent at home and suddenly you're whispering with your spouse in the other room. They can hear that when they can't hear you calling their name to come eat dinner or whatever it is. Kids are always listening. So be really mindful of what you say in the heat of the moment, at the scene of an accident, while you're in the emergency room, because kids will hear it and they will remember it. And it's some of the really distressing things sometimes that they remember, like hearing someone say, oh, these people shouldn't be alive, or, something like that, or even placing blame on someone in that moment. This is all this person's fault. That's really hard for them to hear. And very difficult. So just remember, they're always listening, and telling somebody they're lucky to be alive or that they should have died is not helpful in any situation. Sometimes we have this desire to look for the silver lining in things and share that with people. But when people are in that immediate moment of stress, sharing what you think is the silver lining generally is not a helpful strategy for providing advice or encouragement. I think the other thing with kids and communication is some kids want to know what's happening to them in a step-by-step way. Other kids don't. And really the only way you're going to know that is to ask, do you want me to tell you step-by-step when I'm going to do this poke or what we're doing next? Versus, do you just need me to do this? This is what's kind of going to happen and should we just go for it? And giving them some control over that and telling them that is helpful. This one voice is sort of been developed in the medical literature to kind of think about how to respond in crisis situations and how to prepare kids for sort of difficult things, such as burn dressing changes and things like that. I think the most important piece of advice in this one is that top one voice should be heard. So you don't want to have 3, 4, 5, 6 adults trying to tell a child what to do. That's just as overwhelming as giving them that string of commands over and over and over again. Is you want to have that one person that has sort of gotten down on their level, maybe taken that minute if they have it to develop some rapport, and they are the voice of people giving them instructions so the kid knows who to listen to and sort of who is telling them what to do, because otherwise kids will freeze or they will act out in a variety of ways. And so one person should be telling that. If you have the luxury of parent involvement, that's very helpful for a lot of kids. Although I will say for some kids, they do behave better in difficult situations when a parent is not in the room. That's just but for the most part, especially for a novel and crisis situation, having their familiar person there is going to be helpful. Giving them, like I said, if they want it, giving them some education beforehand about what's going to happen. Whatever the child tells you they're feeling or whatever, validate that, say yes, and don't lie again. If it's pain, if it's going to hurt, say, yeah, it's kind of going to hurt, but here's what we're going to do to help manage that hurt. Don't say, no, it's not going to hurt if it's going to be extremely painful. Offer comfort in the most non-threatening position. This is something like if a parent can hold them during something instead of having them lay out flat on the bed, that's less threatening. So just kind of thinking about what can be different, or even sitting up versus having to be held down. Those kinds of things are less threatening and are going to be less traumatizing moving forward. I know sometimes we have to get things done and we have to do things that are traumatizing, and I respect that, but the more we can just think about a few of these minor changes, we can reduce that impact of trauma on a child. Distraction is always helpful. And then just like that one voice, eliminate unnecessary people. So it's overwhelming for a child to lay in a room with a lot of people. And so the more we can reduce that and just the people that absolutely need to be in there, it's going to reduce those symptoms of trauma and help them cope more effectively with whatever is happening in that moment. Another helpful tool, and this is true for all of us as human beings, we want to have a sense of control and mastery over our world and our environment and what's happening to us. And things that we feel like are out of control cause a lot of anxiety. We don't like the unknown. We don't like not knowing what's going to happen or not knowing why something happens, those kinds of things. So we find that difficult. They did experiments long ago in psychology where they would ask somebody to hold their hand in cold water and tell them that they could take it out whenever they wanted to, but they were going to try to hold it in there as long as they can. And when they told them they could stop at any time they wanted versus telling them they couldn't, people rated it as less distressing, less difficult, less cold, all of those things, because they had a sense of control over when they could make the difficult things stop, and that decreased their sort of emotional response to that event. And so we know that control is so important. So there may be very limited ways to give control. I think the hospital is an environment in general where we have very little control over things. I often talk with kids about, like, there is no other place where people just come barging in and out of your bedroom and your bathroom all day long. You have no privacy, you have very little control. And so finding ways we can give control in these emergency situations is really helpful. And one way we can do that is give choices when possible, and making sure that the choice that we're giving is actually a choice. And so do you want to do something is probably not the choice, because probably that thing needs to happen. Like, do you want me to start your IV? Probably not an option, but you might have some choice of, should we try putting it, here, or should we do this thing first or this thing first? If those are truly choices we can give, then that helps them feel a sense of control and is going to reduce anxiety and therefore reduce kind of trauma moving forward. If possible, it's nice to ask for permission sometimes to do something, because again, that gives a sense of control, especially since we spend so much time teaching kids, this is my body, this is my space, those kinds of things. And then obviously medical things are the exception to that, but it's still nice sometimes to ask for permission and tell them why you need to sort of invade that space. It helps them feel safer. In some painful procedures, or even difficult tasks, it's helpful to use what I call break cards with kids. This is just a simple index card with the word break written on it, or stop, or whatever might work. And if you're doing something that takes a chunk of time, you give kids a couple of these cards and you say, when you need us to stop, you hold up one of these cards, you turn it in, and we will stop for 1 minute or 2 minutes or whatever it needs to be. And just giving them, again, that sense of control oftentimes will help them tolerate that procedure for much longer than they would otherwise. And it gives them control over it, and it gives them an appropriate way to get us to stop something versus, using behaviors and acting out and becoming out of control as our way to get something to stop, because that is a way that often works for kids. But if we give them a more adaptive way to get something to stop, it works better. And like I said, what I find and what over time happens is you give kids these break cards, and most often they don't ever use them, but just having them helps them feel better, and they're able to get through it, and they feel less distressed by it. And it's such a simple tool to have. You probably talked a little bit about these kind of tools in your last talk, but sometimes just thinking about what that sensory input is can help kids calm and provide a less traumatic environment. So if you can dim the lights, if you can reduce noise, offer them headphones or earplugs or something like that, be quick to respond to extra beeping and alarms and things like that, because lots of kids and parents will tell us afterwards that hearing different things, alarms, hearing those machines causes that panic reaction because they don't know what all those alarms mean, and it's scary. They're meant to cause a reaction in us, and they do for those kids for a long time. So the more we can reduce their exposure to that, we're going to reduce their trauma reactions over time. And I think at the scene of an accident, especially if there's a prolonged extraction, things like that, headphones could really be a helpful, easy tool to have to reduce that impact of that noise and the sounds around them and things like that. But again, even if they have headphones on, do not make the mistake of thinking they're not listening, because they are still listening, and they can probably still hear what you're saying because they're always listening. Again, with kids, it's trying to minimize wait time as much as you can, because that's time for anxiety and stress just to keep continuing to climb and get worse. And so we try to kind of keep things rolling. Once we start, we kind of get through it in a short chunk of time so that we don't prolong their anxiety. Because for some things, there's going to be a level of anxiety sort of no matter what we do to prepare kids for the experience. And so if we just keep delaying it, we're prolonging their anxiety and making it worse for them and making it unpredictable. And then the other tip I would say is the louder a child gets, teachers are usually good at this one, the quieter you should get. Kids look to adults for how to understand and manage their behavior. And so if a kid is crying really loud and you start to whisper at them, they will usually over time naturally get quieter too. You will de-escalate them by coming in quieter and softer rather than yelling to be heard over the top of them. They will match you. These tools right here on this page, which I think you guys talked about earlier today, are probably some of your best strategies for helping kids with autism spectrum disorder cope in the moment, because a lot of them have some significant sensory sensitivities. Reducing some of that can be very, very helpful in terms of helping them cope and reducing traumatic stress. Other tools for calming that are going to be helpful in sort of reducing stress and anxiety. Young kids like swaddling, so wrapping them up in a blanket or having a weighted blanket or some deep pressure. For older kids, just feeling that security, sort of like you're in that cocoon, is comforting for most of us. Offer a security object. I think a lot of EMS providers have gotten pretty good at having, new stuffed animals in their cars and trying to offer something to kids in sort of situations to try to give them some object to sort of create comfort and security. The other thing is to look around to see if there's something, or ask a family what the kid's preferred object is. And if it's when they're in the hospital later in the emergency room, tell them it's okay to bring this from home. It's fine to have these things here, whether it's a pacifier, a stuffed animal, blanket, whatever it is. because those security objects go a long way in being soothing for young children and sort of reducing that stress on their body. Shushing or white noise or gentle music can be very calming for a lot of people. It also can help cover some of the scary background noises that exist in hospitals and in emergency situations. So finding, some music or singing with them, those kinds of tools are going to be very helpful at reducing the impact of trauma. Also distraction. Distraction is a great method for helping kids calm down, helping kids get through difficult things, and reducing kind of re-traumatization as the time goes on. So songs, games, distracting questions, counting, all of those kinds of things, whatever you can do to engage them. And this is where, if you have kids or you're up on the kids' stuff, knowing what they like is really, really helpful. Or if you don't know much about what they like, ask them to teach you. My kids are young, and so I see older kids sometimes, and I've had more mind-numbing conversations about Minecraft than I would ever like to have, but kids love to teach me about all the details of Minecraft. And because there are so many, they can talk about that for a very long time. And it can be a good tool for distraction. And it's something that brings them joy, so it's going to help with that emotion regulation. This is just a little handout we use. So there is a lot of information on here, but this is kind of from the Child Traumatic Stress Network that talks about what are tips for parents, but I think this also pertains to some emergency care providers and emergency room providers that are meant to help kids cope with being in the hospital. So the hospital is a potentially stressful, it is a stressful and potentially traumatizing environment. And so what are our best things to potentially help kids do their best in that environment? And so, being patient, giving praise, letting them know what's happening, allowing them to express emotions, all those things are very, very important. Talk about feelings. It's even okay to model your feelings as an adult around them, because kids don't necessarily know how we sort of think or cope with things unless we sort of talk out loud as we do it. To them, it just looks kind of magical. But it's okay to cry in front of a child and to say, I'm sad, or this makes me sad, and to model that it's okay to have those feelings. There's sort of an unwritten teaching in US culture that negative emotion's not okay. We shouldn't cry. It's not okay to cry. But it is okay. And it's okay to have those emotions, and we want them to know that that's okay. And reassuring them that they have not done anything wrong to make this bad thing happen is really important. I often emphasize to young kids that the definition of an accident is that nobody meant for something bad to happen. Even if there are poor decisions that are made, etc., in an accident, they still didn't mean for anything bad to happen. And that's helpful for kids to reiterate to kids sometimes, is you didn't mean for anything bad to happen. And that's the definition of an accident. Because as adults and as kids, we all take on guilt, and that guilt is not helpful for our psychological health. The other thing that we often talk to kids about when we talk about feelings is trying to tell them to be brave. And bravery is a wonderful emotion. But kids often define that wrong. And so I often tell kids, being brave does not mean that you don't feel fear, because they see superheroes and all these people who are brave on TV shows, but they're never afraid of anything. And so they feel well, I'm not brave because I'm afraid of things. But being brave is actually doing something or trying something in spite of being afraid of it, or being fearful, or being scared. And so sometimes defining that emotion for them is a really helpful tool in managing those difficult things, because they'll say, but I'm not brave because I'm scared. Well, no, you can be scared and still behave in a brave manner. And that's helpful for them to hear. I think in hospitals, as much as we can keep consistency, keep caregivers as constant as possible, reduce transitions, that is going to help young children cope. Fewer people in the room. So I've been part of academic medicine in a teaching hospital for a long time. So rounds is 12 people marching into somebody's space, which is not helpful. for lots of kids for coping with the hospital, because they don't like that being the center of attention, having people sort of talk over them. Remembering to talk to them when you walk into a room and identify them as important instead of just looking directly to the parent or just going about your business is also really important for helping kids cope in the hospital. So now we'll just kind of do a little bit of kind of talking with psychological first aid and sort of some of the quick principles of that kind of apply to things you can do in the moment to kind of help kids cope. I like to think of psychological first aid as being sort of based on Maslow's hierarchy of needs. And Maslow's hierarchy of needs has been around in the literature for a long time. And it sort of talks about like what our needs are as basic humans to sort of reach the epitome of development and being a human, which is self-actualization, where you have your full potential, you're creative, all that great stuff. Psychological first aid is not focused on that. It's not even focused on the middle tiers. Basic first aid stuff is focused on those bottom tiers. Safety needs, security needs, basic needs, those kinds of things, because we can't do the top things at the pyramid without having a stable base. And so we need those things at the bottom before we can move on to the things at the top. And so psychological first aid focuses more down there. It's not long-term therapy. It's not addressing long-term things. It's really focused on immediate needs. And so these are sort of the basic kind of tenets around psychological first aid. You're trying to instill some hope. You're trying to fill all those basic needs. You're providing listening. You're providing some comfort and connection, human connection, as well as connection with resources. You're providing basic safety. You're protecting them from further traumatization or danger, because that's sort of first on the need. You cannot address symptoms of trauma if you are not safe. That's just sort of basic needs first. Or if you don't have enough food, of course, you don't have enough psychological energy to address other things. So ensuring safety and comfort is, that assuring immediate safety, moving away from the scene of an accident, getting them to a quiet place, attending to those physical needs, whether it's blankets, clean clothes, shelter, those kinds of things. Paying attention to really reunite children with their families if we can, or not separate them from caregivers. If caregivers can ride in the ambulance on the way to the hospital, if that's an option, those kinds of things, because being separated from your secure base or your caregiver has a significant predictor for future traumatic stress symptoms. And then trying to protect them from any additional trauma experiences or, more traumas. So if you're at the scene of an accident, if you can put up a barrier, if you have to move a body across their field of vision while you're still extracting somebody from a vehicle or whatever it might be, trying to reduce those future exposures and provide that safety and comfort. You want to validate feelings and pay attention to feelings. And listening is something that is harder for people to do than they think it is to do. Because as humans, and oftentimes, especially as people in a helping profession, we want to be able to help and fix things. However, feelings are not immediately fixable, and they are not wrong, and so they don't necessarily need to be fixed. They need to be heard, and they need to be validated. But just listening is probably one of the hardest things we ask people to do, and oftentimes it leaves the helper feeling somewhat helpless, or not knowing what they're supposed to do. And so then they jump into advice giving mode and try to fix it, try to offer all these solutions when that is not where the person is at that time. So usually the strategy to be a good listener is to engage in some reflective listening, which is when they stop talking, either reflecting back the feeling you heard them say. So I'm hearing you say you're really scared, or I heard this, and sort of paraphrase what they've just said to you so that they know you're hearing them and that what they're saying is important and valid. It's okay to normalize reactions, to say this is a really normal thing people feel at this point, those kinds of things. Those are helpful ways. But trying to fix them or trying to tell them why they shouldn't feel that way is not helpful, or saying, well, you should just feel lucky to be alive, or at least this thing didn't happen. Finding that silver lining here is not a helpful tool in this moment, because when people are in the middle of this, they don't feel lucky at that moment, or maybe they do a little bit, but we have to embrace this. And when it comes to feelings, is that human emotion is incredibly complex, and we can feel very competing feelings at the same time. I talk about this with my NICU families a lot. You can be grateful that your baby is alive, and you can be really angry that it happened this way, or that, you know, nothing about how you expected your child's entry into the world is the way that it looks. And that's okay, because those things are both there, but everybody wants to tell them to only focus on why they should be grateful. And that feels very invalidating and increases trauma, because if you don't feel heard, you're going to stop sharing your emotions, and that is going to cause you to avoid them internally and increases your risk for traumatic stress in the future. So most important thing, and is a tool you can give other people too. So somebody who wasn't at the accident, to say, how can you help them, is just listen to them. Don't try to fix it. Don't try to tell them why they shouldn't feel guilty or why they shouldn't feel whatever. Just be willing to listen. Connecting them with resources. So knowing your local resources to help people meet basic needs. What are the Red Cross? What are the shelters? What are, you know, sort of immediate need things for food, shelter, water, those kinds of things. And then know your local trauma resources. And on top of that, I would say vet those resources, that especially mental health resources, that you're willing to sort of connect people with, to make sure that they're offering evidence-based care for trauma, because we don't want to cause more trauma. We want to help them with their trauma. So your evidence-based trauma things that you're looking for, buzzwords, would be TFCBT, which stands for trauma-focused cognitive behavioral therapy, that has amazing literature support for children and adults. CSTSI is sort of an early family intervention, actually aimed at mitigating the effects of trauma. So if kids have just a few symptoms early on, they're actually trying to prevent the development of PTSD. So it's an early on intervention that's available. In the adult literature and sort of older adolescents, EMDR is a empirically validated PTSD treatment. So you're looking for those evidence-based trauma care providers to be able to refer your kids and families to after they've experienced a traumatic event. So we've talked about a lot of things you can do. I do want to just point out a few things that aren't very helpful. Don't force someone to tell their story in the moment. At some point, it will be the job of a trained mental health professional to work through being able to tell their story. But if they're not at that place without that trained person, it's not helpful to help people, force people to tell the story or to probe them for a lot of personal details. Do not say, you know, everything's going to be okay, because you don't know that at that point in time. And that's not helpful for someone to hear in that moment, or at least you survived, those kinds of things. Stay away from those statements. We all say them with good intentions and well-meaning, but they are not taken that way by someone in the middle of a traumatic experience. Don't tell them that their reaction is wrong or weird, or that you've never seen that before. It's not very comforting. And don't make promises you can't keep. And I think about this sometimes when we're separating a kid from their parent for some reason or whatever. Don't tell them that they'll see their mom the next day or whatever, unless it's a promise you can keep. Don't make it. And then the last thing, when we're talking about psychological first aid, that I think is so, so important, is self-care of all of you as providers of emergency services. This is a stressful, difficult job. You're at high risk for secondary trauma, vicarious trauma, which I'm sure, compassion fatigue, I'm sure all things you've heard before. I think the biggest thing is to create a culture of knowledge around that. And remember that, yes, you did choose this profession knowing it would be hard or that you might see difficult things, and you are human, and that means you will have emotional responses to the things you are witnessing. I think so often people in helping professions think, well, I shouldn't feel this way about this thing. This shouldn't affect me because I'm a nurse. I am an EMS provider. I am a doctor. I am whatever. And I knew this was going to be the case when I got into it. You can know that. It doesn't mean you don't have human reactions. And so I think this is something that is getting more attention in recent years versus before, thinking doctors and, emergency medical people were supposed to be able to just move on from one thing to the next and just shift to going home and have no reaction to that. That's not true. You get to have an emotional reaction. I think it's just important to know for yourself what your tools for stress management are and make time for the things that bring you that joy or stress relief. Set limits, know your boundaries. It's okay to say no. It's okay to step back from things sometimes. I used to work in Milwaukee, Wisconsin, which has a major gun violence problem. And on my team, I one time said, I can't do another childhood GSW. I've got 6 GSWs right now, and I can't. I don't have the emotional capacity for this. I can take any other thing that you want me to take, but I can't take this. And just being able to know what those limits are and what you can handle is really important. And hopefully you have peers and an organization that's able to support you in being able to say that. Utilize your peer support and supervision, and know and accept that you cannot change everything. I think sometimes we wish we could fix really yucky home situations, stressful parts of things, but we can't. And knowing that and being able to accept that are a practice, not a perfect, yes, I get this. It's something we have to practice every day to wrap our brain around. And like I said, I'm sure you guys you could do a whole presentation on compassion fatigue and provider self-care, but I just feel like it's really important to throw that in there with this audience. All right, so that is what I have for you in terms of prepared stuff. So now I will stop sharing and let the questions, if there are some.
Yeah, we've got some great ones. So first of all, just thank you for sharing all of that. That was a lot of information. You covered it, very well and learned a lot. So I'm just going to start going through some of the questions here that, I've got from the chat and the Q&A. So this first one here, I think is a really good one. How do you approach the kiddos that, they were part of a violent event where someone tried to cause them harm? So, domestic abuse, child abuse, approaching those kids who are probably already just traumatized by people in general.
Yeah, so I think the first step is ensuring safety where they're at now. So they are safe now, because that providing safety is that bottom of that hierarchy. And it's so important to let kids know they are safe now, and you are going to work to find them a safe place to go after that. Because lots of these kids spend a little bit more time in the hospital or in sort of middle ground things that we have to, again, very much don't make a promise you can't keep. Don't say you're never going to let anybody hurt them again or whatever, because we can't make that promise. And we don't want to breach that trust, but we want to tell them they're safe right now. And we want to try to provide as much consistency as we can and, provide those security objects and those kinds of things, and let them talk in what comes out. So especially in emergency medicine environments we don't need to force them to talk about what happened. That's for the forensic interview. That's for other things. If they want to talk with you, you just say, you're listening, that's so scary, validate those feelings, but that's really where you start. You don't have to have an answer for it. Again, we want to fix it. Our natural inclination is to want to provide this thing that's going to make it okay for them. What happened to them wasn't okay. But we're going to do our best to make sure that they are safe in the future.
Thank you. This is another good one here too. This is someone who's newer to a region, and they're trying to work, finding some resources and just understanding for kids with PTSD and suicidal ideation, but especially in Native and tribal regions where there's, some, higher incidences of like violence and abuse. Do you know of any good, resources or evidence around, how to deal with that population specifically?
I am somewhat of a new transplant to this region too, and I am being in North Dakota now. The Native American population is much more prominent than where I was before this. And I would say I agree. I'm noticing some of the same things. I would say get to know usually IHS or Indian Health Services on specific reservations and stuff has some mental health providers. Get to know them sometimes. But I think with mental health in the American Indian population, you're fighting a lot of stigma and a lot of beliefs about mental health and stuff that can make it very difficult to get kids the help they need. So I think the more things we can do as communities and as providers to reduce that stigma around mental health, it's going to have a slow impact. It's not a fast fix for one patient, but it's we have to be doing. We have to be talking about depression and suicide and drug and alcohol abuse and all of those things. And we have to be normalizing mental health treatment and normalizing those things, because that stigma is a significant barrier to services among this population. And I think the other thing we have with this population is historic trauma. So you can have whatever trauma they are experiencing now, but there is this historic trauma and this culture of trauma that they have been raised in that increases their risk for traumatic stress exponentially.
Right, I just had another one pop up here too. So in the emergency scene, kind of what are some things the provider can look for when they're, deciding, like maybe the child's not like critically injured and it's like, how do I know, is it okay for me to approach them and kind of get in their space, or should I maybe let them kind of come to me? Just kind of striking that balance between, taking care of them, treating them, but not, not trying to cause any, additional, panic or stress as much as possible.
Yeah, so I think you're triaging a little bit. You're starting, with that personal bubble, at least that arm's width for that kid, so they can have that personal space. You're getting down at their eye level a little bit. You're taking that time to build a little bit of that rapport if you have that luxury. And then asking that, saying, I have to feel your belly, or I have to do this to check for injuries. Do you want to help me, or do you want to lift up your shirt? Giving them some of those choices, if you have that option, can really help give them some of that control and reduce that stress. Or even if a parent can help be involved in some of that, if that's an option. Or picking that non-threatening position, if they don't have to be laying out on a stretcher or going into the ambulance and saying, you know what, I can do this right here, with your mom or with whatever, or where we're at, I don't have to move you. Those kinds of things sometimes can help in that situation.
Gotcha. And this one's kind of more on some of those, I don't want to quite say distraction techniques, but just like, trying to get the child in the moment to focus. So they said, what about using statements like, first and then, or, what if, can you see an object of this color? Just trying to like bring the child back to this moment. Are there certain situations maybe, or those techniques are going to be better or worse, or is it going to be more dependent on that child?
Yeah, so I think the game of sort of I Spy or find me something blue or green, whatever, can be a great distraction technique, because that's using what you have available to you, which might not be a lot in some situations. As long as you can keep them focused where you want them focused and not looking somewhere that might be more traumatic. So I think that makes a difference. What was the first part of that question? I feel like there was kind of two different things there.
It was also kind of like, okay, first we'll do this and then, maybe like trying to, first we'll do this and then, maybe like the tougher part,
Yeah. So I think that's the sort of preparing them for the procedure is fine. But I think when we're sticking in the moment, we want to stick with one step at a time, because when our brain is under stress, it's very hard for us to pick up that two-step command, the first this, then this. Totally appropriate for a lot of kids in not stressful situations. It's a good way to do it if you have a reward. So once we do this, then you can have this thing, or we'll be all done, or whatever. That works really well. But if you're trying to get them to do, first we're going to do this, then we're going to do this, I want to keep it in that one at a time, because they might not hold on to it very well because their brain is under extreme stress. But if it's like, if we just get this done, then you can be all done, or I'm going to give you your lunch or whatever, then it's a good thing, because it helps them know they're working hard for that reward, this thing they want afterwards.
Right. And then, so, most times with dealing with children, I know this is something you have a lot of experience with. It's not just the child, it's also that family, you're taking care of that whole family unit. So what are some tips for, you're trying to, mitigate and minimize, the stress this child's going to take away, but, at the same time, you've got this parent, who's also dealing with that at the same time. Any tips on managing that, dual dynamic?
Yeah, so I think sometimes for parents, it's okay. It's a good idea to ask them if they want to watch certain things or how they want to manage that. Like they want to be there for their kid, but sometimes watching a procedure is maybe not the best thing in the long term. Can we shield that in some way, or can they say, this is going to happen and I really want you to focus just on looking at your child in their eyes or paying attention to this? Or sometimes for parents, I have them do a focus on something that's perfect about your child right now, because it's so easy when there's a lot of medical equipment and injuries to focus on just that. And that's really distressing for parents. So find the one part of their body that isn't scraped up, that isn't bloody, that isn't marred by a ventilator or whatever it is. Find that and focus on that. Look at that, memorize it, take a mental picture of it, and really do that piece to try to draw their attention away from those things that are further traumatizing. I think the more we can support parents, the better kids' outcomes are going to be too, because we know kids look to the adults in their life as to how to respond in a stressful situation. And if we can help the adults cope, it's going to help the kids cope too.
And actually, in that same vein, I just had another one. So, you know, what about in situations where the child really wants that parent present, but the parent, you know, they might be actually making things a little bit worse, you know, because they're concerned, you know, they're scared, maybe they're like impeding care, just trying to be there for their child. Any good tips for providers on how to manage that?
I feel like that's always one of those really sticky situations. Sometimes what we do in the hospital environment, we have the luxury of having child life providers who will come in at a time when it's a planned thing and make like a coping plan, and it include the parent or not include the parent. And if it doesn't include the parent, then we give the parent something specific to do otherwise, so that they have a job for that time as well, which we might focus for them on their self-care. Like, this is a really good time for you to step out and take a shower and do this, because this is our plan and we're going to follow this. And it helps us keep things on track, those kinds of things. But usually we have to give somebody a job, because everybody wants to feel helpful. And if we give them a job, that's usually more effective than just saying, you know, you're not very helpful to your child right now, so we're going to have you step out. Doesn't usually work very well.
Oh, I'm sure. And I don't have any in the Q&A box, but I do have one that I've been thinking about, just because I know, you know, all the different states, you know, the cultural barriers are going to be different, but, you know, for when providers run into a language barrier, you know, and like you said, the first thing you want to do is you want to, you know, hit those bottom of the pyramid. So safety, security. If you've got a, you know, a child who might not speak English, what are some great ways to kind of convey those, you know, with, you know, out being able to actually use words? Because that can be hard.
Yeah. So nonverbal communication is obviously very important. How our face looks, how stressed we are, matters a ton, whether we smile. But with culture, you always have to take into account whether this is a culture that makes eye contact and expect for that, or how they express emotions. And so I think knowing what some of your sort of niche cultures are in an area and how they sort of interact is really important, and what's sort of normal for them. Even when we think about how families express grief, like wailing is very normal in some cultures. It's very distressing for us as Americans to hear somebody wail at the top of their lungs, but it may not be distressing for that child, because that's how they express grief or fear or whatever. And sort of knowing some of those things, and then really trying to use your nonverbal communication, use gestures, use quick drawings or pictures to try to help them get through that if you don't have the immediate, you know, access to someone to help reduce that language barrier.
And then one other one here, you know, for some children, and these are, you know, maybe, you know, because of whatever circumstances or environment they're in, it's not just, you know, a single incident of trauma. It's, you know, their whole lives might be a series of just, you know, really unfortunate traumatic events. So how can providers kind of interact with those kids who might have some atypical reactions, or just, you know, these deep-seated fears? Some good tips in the field for how to manage that.
Yeah, I think cumulative trauma really can change that reaction and that sort of stress response thing. So if you are seeing a reaction that seems not in proportion to whatever the event is, I think your go-to thought should be, what are the cumulative effects of trauma here? How is this kid's or adult's brain different and developed different than the other person's? Why am I meeting this resistance so strong, or such a strong reaction? More than likely, they're not just trying to be difficult. It's probably the cumulative effects of trauma and their interaction with the healthcare system that is impacting their response. And so I think anytime we see reactions that we sort of deem as out of proportion to the situation, that's usually a good sign of, oh, this is probably a trauma reaction. This is probably cumulative trauma, and trying to kind of, you know, use that to, in terms of how we either take that personally, or how we respond to it, or how we lay out sort of the rules, things like that, I think makes a big difference.
And I just had a couple more come through, and then looks like we're getting close to time. So these will probably be our last couple. So what is the best way to separate a child from a parent that's suspected of harming the child? So, maybe that story injury doesn't quite match up. And you want to, talk to both of them separately, but there's that insistence of, well, I need to be here, how to handle that kind of dynamic.
Yeah, I mean, typically the nice thing about that is we have teams of people whose job it is to sort of identify that, because as emergency providers, we don't have to do the investigation of abuse, I think. And sometimes remembering that it's not our job to decide if this is true or false. It's just our job to report our suspicion. And that's where our job ends. And so, we don't necessarily have to get that information in that moment. There are people who are specifically trained to do that, whether it's law enforcement or child protective services, care clinic, those kinds of things, abuse clinic. It's just sort of remembering that we don't have to do that. And it's a red flag if they're not willing to separate potentially, but your job really is to just report your suspicions. And that's sort of what I tell myself in that kind of situation is like, I don't have to ferret this out. This isn't my job. If something's not right here or the injury is not matching the story, you don't get retinal hemorrhages from falling off a changing table or whatever it is. That's always the I rolled off the couch story that goes with head injury or something like that. I think that doesn't have to be most people's probably role on this particular training. It's just remembering that your job is to report, and after that, it's someone else's job to investigate.
Absolutely. And this last one here, I'm sure this is a tricky one, especially with kids. In regards to consent, how do you respond when the child says no? And hopefully, like you said, you gave some tips on trying to avoid the, well, can I do the IV? Can I do this? Because you're going to get that no. But if, they straight out and they're like, no, but it's something that has to be done. How do you kind of manage that?
Yeah, so I think you're right. The first is make sure you don't give choices where there aren't choices. So like at home, I don't ask my kids if they want to clean up. I tell them they have to clean up. And so I think that's part of it. I think the other piece is saying, I hear that you don't want to have this happen, but this is something we need to do for X, Y, or Z. And then if there's a way to sort of say, do you want to do it this way or this way? You can do those kinds of things. But I think it's reiterating that you heard them say no and you're not ignoring them. You're not completely going past them, but that certain things have to happen. And then in a lot of these cases, I think the faster we can do things, the better it is. Once we've given that explanation once, we're pretty sure they understood us. They still don't like it. They're still asserting their autonomy, but it has to happen. Then our job is to probably get it done fairly quickly so that we're not prolonging this traumatic, stressful experience, and we're getting it done, and then we're done and it's over with and we can move on.
Absolutely. Thank you. I think that's a great way to handle that. And that looks like it wraps up our Q&A. So just again, thank you so much for, spending your evening with us and sharing this. This has been super, super informative, very helpful. If we have any questions that come in afterwards, we'll make sure to follow up on those. And for all of our attendees, thank you guys for being here with us tonight. You make this possible. We're so grateful for you. Make sure you complete those evaluations. Please give us a little bit of time and we'll get those certificates out to you, and reach out to your state coordinator with any questions. But otherwise, everyone, take care, stay safe, and have a great night. So, bye.